All right. Good morning, everyone. Welcome to our 2024 Enhancing Community Resilience to Improve Maternal Health workshop. It is an honor to be with you all here today in Des Moines. And as we gather to discuss the vital role of doulas in improving maternal health outcomes for moms and birthing people, as well as their role in advocating for reproductive equity. The organizations represented here today are on the front lines, addressing this urgent need within their communities. We are here with a shared mission to deepen our understanding of the transformative work that doulas and community-based organizations are doing in maternal health, to exchange knowledge, and to build strong, lasting partnerships. We are joined by a diverse group of experts, healthcare professionals, and advocates who are all dedicated to improving maternal health outcomes and supporting the invaluable work of doulas. I would like to express my sincere gratitude to the event committee who helped us plan this event today, our presenting sponsor, Argonon, who made this workshop possible through their dedication and support. I also want to thank everyone who registered to attend online. I think we have about 90 folks registered to attend virtually, so thank you for joining us in your capacity at home. I want to start off with introducing our keynote speaker, who is also a board member of March for Moms, Chanel Portia Albert. Chanel L. Portia Albert is a remarkable mother of 6 children and an esteemed founder and CEO of Ancient Song Doula Services. Chanel is committed to improving infant and maternal health. This commitment led her to create Ancient Song, a global birth justice organization dedicated to eradicating maternal and infant mortality and morbidity among Black and Latinx communities. Chanel's passion has also taken her around the world, including Uganda, where she served as a maternal health strategist, and to Ethiopia, where she is working with the Ministry of Health to establish a doula program in Addis Ababa. Chanel's groundbreaking efforts in birth and reproductive justice encompass research, care methodologies, and a steadfast focus on centering marginalized groups and people of color. Her work is rooted in a human rights framework, driving transformation within birthing rooms and instigating institutional reforms that address implicit bias and racism. Her expertise has been sought by organizations such as AMCHIP, the New York City Department of Health and Mental Hygiene. She also played a vital role in the creation of the New York City standards for respectful care at birth. Furthermore, she has been appointed as a commissioner by New York City Mayor Eric Adams to the New York City Commission for Gender Equity. We are welcoming Chanel virtually. Thank you.
Hi, greetings, everyone. I wish I could see your beautiful faces. First, I want to just say thank you to March for Moms. Honored to be a board member and to serve with them, but also to all of my folks in the Midwest. What up, what up, what up, what up? I hope that you are well and you are centered. So I don't have that much time with you today, but I want to make sure that I address some of the things that are happening within the reproductive health world as it pertains to us as doulas, as advocates, as individuals who are in the space, who are working with our communities every single day to center hope and equity, accountability, and transformational and systemic change on a daily basis. And so I'm going to share my screen because I wanted to, I hope that you all can see it. Again, I can't see you, which is always like a little weird to me, but here we go. So I'm just gonna, let me make sure you can see my screen. Oh, come on. Here we go. All right. So DOULA Dynamics, advocating for reproductive health equity. Again, my name is Chanel. I'm a mom of 6. And me being a mother is a catalyst for everything that I do. My children are the reason why I got into this work to begin with. And throughout my work, I've had the opportunity to be able to work with various different individuals who are in the reproductive policy and birth justice space. And all of that has shaped the ways in which it has informed the way in which I show up and how I am centering the work as a doula, right? Because I'm a doula first. So I wanted to really start with what is reproductive equity and how does it pertain to the work that we do as doulas? And for those of you who are not doulas in the crowd, it's okay. It's totally fine. We still see you. But we are working to ensure that everyone has the resources, rights, and respect that they need to make informed decisions. We're uplifting quality of care, ensuring that that care is free from discrimination and bias. We're promoting equitable workforce conditions and uplifting a living wage in everything that we do. We're removing burnout and system of burnout that happens within the role of doulas, and us showing up for community every day. And we're centering mental health access, right? And so what does it mean to center the access of not just the individual who we're providing support to, but also for ourselves, right? As we are not separate from the work that we do every single day. And that role, and that intersecting role that we play as frontline advocates, as champions for human rights, as catalysts for identifying birth injustice and breaking systemic barriers, comes from our deep connection that we have with community, comes from our interactions with one another, comes from us being not just adjacent to community, but deeply rooted within understanding the intersections of care, understanding the ways in which we ourselves are not separate from, because we are too experiencing inequitable housing or not having access to housing because of the high cost. We too may be feeling the brunt of food insecurity or high cost of food, right? We too are parents within this space, or aunties or cousins or grandmothers. We too are witnessing not just the injustice, birth injustice, when we are supporting someone on a one-on-one basis, but also how we are able to access reproductive health care ourselves. So we are not separate from the jobs that we do. It is intrinsically connected to how we're able to show up in the world and how we're able to show up to support other people, right? And by doing that, we are systematically breaking down the barriers that we see every day, because we too are experiencing them when we go in those birth rooms. We too are experiencing them when we're trying to identify resources within our communities. We too are faced with the decision of what does it mean for us to show up as our full selves, or have to taper that down, right? Based on the fact that we know that our just very beings can oftentimes be a threat to other individuals, because they don't want to see us as full humans, right? They don't want to see us as the living, breathing, beautiful, joyous, amazing individuals who are cultivating community care frameworks every single day. And so as birth justice advocates, we are focusing on addressing systemic inequality, that affect maternal and infant health outcomes. Again, because we are not separate from the issue, we are also intertwined within it, because it connects to who we are and how we show up every day. Doulas are not just individuals who are addressing health disparities. And I'm just going to put that out there, right? Because when we oftentimes hear the conversation around doulas, we hear that we reduce preterm births and low birth weight babies. We are hearing that we help to reduce the stress and trauma associated with childbirth and what happens in the birthing room, right? We folks know that we're connecting pregnant and parenting individuals to vital resources. Yes, that is only one aspect of the work that we do, right? The other aspects of the work that we do is really centering policy and advocacy every single day, right? We know the field. Again, we know that because we're experts in it, because we're experts in our own care and our own centering our own bodily autonomy. And we're helping other individuals to center theirs and what it means for them to affirm their bodily autonomy and their basic human rights every time they show up for reproductive health access and care services. Some of the things that I want you to know as doulas is that you have the power to make transformational changes, right? On a city, state, and federal level, right? Some of the key areas that I really want you to stay abreast of is understanding access to quality maternity care. What does it mean for us to have access to quality maternity care? What does it mean within your area, right? Because it looks different based on where you are located. It looks different in rural areas. It looks different in the Midwest. It looks different on the East Coast and the West Coast. It looks different in the South, right? But whatever that means to you, understand and be able to identify those and articulate those in comprehensive ways, right? Maternal mental health services and resources, not just for the people that we are providing services for, but also for yourself. You need to be advocating for that as well. As healthcare providers, we can't show up for people if we are showing up and not having the opportunity to be able to center ourselves in effective ways, right? We're talking about reproductive workforce development, not just for doulas, but also for midwives, also for perinatal community health workers, also for nurses, right? Because all of this intersects. We are not separate of, right? This is also abortion access, right? This is providers. How does that one affect the other? When we are not allowing for the workforce to be present, then we are already putting folks at a disadvantage. We need comprehensive reproductive health care access. We need folks to be able to get a child tax credit, right? So that they can continue to get the resources that they need, like diapers and wipes, put it towards child care, which is completely and totally, it doesn't make sense how much it costs to want to have children, right? And to raise them in healthy and loving environments and be able to do that with the resources available. And we can't do that if we don't have those resources, right? So which means we have to keep pushing for them every single day. Medicaid and insurance reimbursement. Those are some of the things that we have been advocating for. I know I have been doing that since 2010. When I realized, like, as someone who runs an organization, wait a minute, this is another stream of revenue for us. This is a way for our doulas to be able to get paid in an equitable way. But it means that we have to have innovative insight, and we have to be breaking down the barriers of what is and know that what can be. You need to know your champions on the city, state, and federal level, right? What are the city and state initiatives and task force that are centering maternal and child health? Who are the representatives that are there that have been championing reproductive healthcare access and equity, right? Connect with them, become friends with them, knock on their door, show up, bring some cookies, bring some coffee, right? Connect with the community-based organizations, right? Nursing organizations, health departments, even the ones where you're like, Lord child, you know, this is a whole beast and I don't even really feel like talking to these people because they don't want to understand. It doesn't matter, right? In order for us to make change, we have to be there. We have to show up every single way. Understand what federal caucuses are open to us that are looking towards shifting the ways in which maternal health and reproductive health access is changing. So we have the Black Maternal Health Caucus, Congressional Health Caucus, Pro-Choice Caucus, the Black Caucus, Bipartisan Rural Health Caucus, the Maternity Care Caucus. Child, we got enough caucuses to last a lifetime. Find out if any of your representatives are on those caucuses, right? And if they are, then go and talk to them, right? Tell them what is happening within your state. Tell them what's happening within your town, right? And in your city. Let them know, because again, although they may be talking about the things, they don't know firsthand what's happening. You're the individuals who have the tools, who have the knowledge base to really inform the way what legislative policy works, right? They're just a vehicle to make it happen, but you're the ones who are actually on the front lines and on the ground. And that can lead to statewide implementation of policies that you know that you need for yourselves and for others, standardized reimbursement rates, right, to create financial stability and ensure consistent and fair reimbursement. So when you're advocating for these things, make sure that you're always advocating for a living wage. And if it's not centering a living wage, then it's not equitable, right? You need to ensure that there's a way and a basis for timely payments. As community-based organizations, and for those of you out there who are CBOs, please do not put yourself in the financial pitfall of taking on Medicaid reimbursement and then you find yourself not being able to have the coverage for administrative costs, being able to cover, payments that may be only partially paid or claims that are are denied. We need to be able to have timely payments, which means that when you are advocating for city initiatives, when you are advocating for Medicaid reimbursement, concurrently advocate for places that, grants that are going to establish startup costs, concurrently advocate for a safety net funding, right? So that the city or the state is establishing that from right off the bat, so that you don't find yourself in this situation where people are like, I really want to, as doulas, be involved in this, but how is that serving me, right? I need to pay my rent. I need to eat. I have a family to take care of. And if I can't do that in a way that centers me, then I really can't be a part of this program. So it's not, so then it becomes this catch 22. So you really want to work towards working towards establishing a streamlined process, right? Have those pilot programs, establish evaluation. And I think we have enough to really go off of, right, from other states. Find the places where it wasn't working, where it is working, and find the ways that you can either intertwine certain things or take out certain things that don't necessarily work for you. Um, Subsidies for low income families, look for them, right? Subsidies that are going to make it easier for doula services to be affordable. I know within the state of New York, we had, payouts where families could get, if they registered, they could get $1,000 or $1,100 every single month. And it was amazing to see, just what people were using the money for, right? Of course, they're using it for their basic needs, right? But those subsidies create pathways for individuals to be able to afford doula services. That also creates a way to reduce barriers to access to care. That also creates a pathway for doulas to get paid an equitable wage, right? So look for those ways, those different unique funding streams that you can incorporate within your state. Allocate again the funding to community-based organizations. If you are an organization and you're doing this work, you need to be able to do it so that you can sustain yourself. I know that a lot of us end up having uh uh high rates of overturning doulas coming in and going out on a revolving basis. And a lot of it has to do with the fact that they have to work other jobs to do this work. Right. So how do we create sustainability? We create sustainability by when they are creating these programs, create pathways for doulas to be able to, and organizations to be able to sustain themselves. When you're applying for grants and other additional funding from your funders, make sure that you're asking for administrative costs. Make sure that you're asking for lines for transportation. Make sure that you're asking for childcare services, right? If you know that your doulas that you have are, have children, well, then how are they able to do their job and also, create a pathway for them to sustain their families? Well, how about you put that into the grant? Ask for that money. If you don't ask, then you won't get it, right? Raise awareness, right? A lot of the things that happen with, doula Medicaid reimbursement, as well as these other benefit programs, is that the public doesn't know about it, right? They know about it from our interactions with it. But the same way that states have used policy to historically discriminate against Black midwives, against other organizations, grassroots organizations, use them same leverage points to force their hand to raise awareness on national campaigns to educate the public around benefits of doula care, right? Develop outreach programs that reach the communities that you want to serve, connect them by creating hubs, right? Because every moment is an opportunity for education. Every moment is an opportunity for change. Go out and be where the people are at, right? Force the other folks that are not there every single day to come into the community. If you have a community giveaway, have them come into the community and to be a part of that so they can see firsthand what's going on. The narrative storytelling is great because it gives a pathway towards human connection, but it also needs to be tied towards the reality of them being able to actually see it, right? Because once they see it, then it becomes tangible, and then you can't deny something that's right there in front of you. And I can't stress enough research and data, right? Evaluate your impact. If you're not collecting data, come on now, step your game up. It's time for us to go to higher heights, right? Get research funding, right? If folks want to know about the work that you're doing, tell the funders that you need a research evaluator. Put it into your grant, right? Evaluate the impact that your doulas are making, right? That data collection is important. If you are advocating for Medicaid doula reimbursement and they're starting a pilot, make sure that they are collecting data beyond just breastfeeding rates and how many times you engage with someone, right? It needs to be full comprehensive data that can really inform policy decisions and identify areas for improvement, and disseminate those findings every year or every quarter if you can, right? So that policymakers can stay up to date. Create a one-pager, a fact sheet about what's going on, even if it's just for your particular organization. But my suggestion is that for all of your organizations within your respective communities, come together, leverage your base, right, that you have, because they like to say that we don't have a base, but we do. You know who your base is? Your base is other doulas, other doula organizations, parents, the ones that you have supported through their reproductive health choices, childcare providers. That's your base, right? Anybody who's working within the space that is a touch point for pregnant and parenting individuals, that's your base. Build it out, right? Connect with those individuals so that you all can highlight the intersections of how things are showing up and disseminate those findings, because all of it is intertwined. It's not separate of. And just know where we at. Like right now, we at the precipice of a political juncture, and we've been at these things before, right? But right now, it's a little bit different, right? I know there's a lot of focus on our president and who's going to be our president, but I also want you to think about the fact that all 435 seats are up for re-election in the House, right, and 33 in the Senate, right? And so your state representatives who are in assembly and are in the Senate, right? Your federal representatives that are in the Senate, all of them matter. Every single last one of them. The judges that are supporting civil cases, every judge that is going up for appointment, you need to know who they are. You need to know their background. You need to be highly involved, right? You need to get people out there and to understand the process of like how do bills get created. You need to be highly informed. And again, you are a great touch point for all of this, right? For getting people to understand the maternal health landscape, for getting them to understand what's at stake. Because right now, when we're on a federal level, when we go to advocate for bills, we find ourselves having to not use certain language. You can't say Black. You can't say Latinx. You can't say brown. You can't say equity, right? No. That's not it, right? We understand why we were pushing that language, because for so long, people were dismissed. People were put in a space where their voices were not heard, they were not seen, right? And they were afterthought. And we can't go back towards that. So it's up to us to really be able to get engaged and to get involved. And again, the only way that we're going to do that is to have those conversations about what does it mean for us to hold people to the fire, right? And the ways in which they show up for our communities. Because hopefulness empowers us to continue our work for justice, even as forces of injustice may gain greater power for a time. And again, it's only for a time. We are the ones, community is the ones who centers hope. Community is the one who has always been on the front lines for creating change. Community has always been the ones who have set the tone for what legislators do. Everything has come out of grassroots movements. You are the movement, right? So we just have to move forward and make the change. I appreciate you all. I provided some resources for you all to tap into. The Black Maternal Health Federal Policy Collective. You have the Doula Data Consortium. If you're looking for data through Sister Web, Ancient Song has created the Birth Justice Institute. You know, you have the National Health Law Program, Black Mamas Matter Alliance, Dad Congress, For Kira, For Moms. Like, check them all out. They're all there to support and to uplift. I thank you. I appreciate you. And I'm open for any kind of questions that you may have.
Did we have any questions for Chanel? Anyone? Well, thank you so much. I'll be introducing our next speaker. Ebony Bailey is a certified birth doula, postpartum doula, and certified lactation specialist, renowned as the founder of Naturally Ebony Doula Services in 2015. Her journey into birth work began with a profound personal experience, the transformative support of a doula during the birth of her third child. For Ebony, birth work transcends mere practice, it's soul work, a calling she passionately pursues by channeling her innate nurturing abilities to support women and families throughout their birthing journeys. With 5 children of her own, Ebony has guided countless individuals through the challenges of labor, delivery, and postpartum recovery. Beyond her role as a doula and mother, she co-founded and currently serves as the executive director of the Iowa Black Doula Collective, established in 2020. Recognizing the urgent need to address disparities in maternal health outcomes among Black mothers in Iowa, Ebony and her co-founders launched the collective to champion birth work centered in Blackness. This mission is to train and prepare diverse doulas to advocate for and empower BIPOC individuals through their prenatal, birth, and postpartum experience. Ebony's leadership extends to mentoring aspiring doulas, facilitating connections between birthing families and holistic reproductive health services across Iowa. She is a steadfast advocate for affordable health care, actively participating in healthcare legislative forums since 2011. Ebony's academic background includes studies at the University of Arkansas Pine Bluff and St. Ambrose University, underscoring her commitment to education and empowering and community empowerment. Please welcome Ebony Bailey.
Okay, I'm gonna try to make sure I get this little clicker right. So as said, I am Ebony Bailey, the co-founder and executive director for the Iowa Black Doula Collective. Our mission statement was already read, so I'm not gonna reread it. So in Iowa, or nationally rather, Black women are 3 to 4 times more likely to experience a pregnancy-related death than our white counterparts. In Iowa, it's 6 times more likely. So what is a doula? Oftentimes I get asked, are you a midwife? Do you catch babies? Or people call and say, oh, I just found out I'm pregnant and I want a home birth. And I'm like, that's great. You have to hire a home birth midwife, but not me, because I don't catch your baby, I don't touch your baby. So a trained professional who provides continuous physical, emotional, and informational support to a birthing person and family before, during, and after childbirth to help them achieve the healthiest, most satisfying experience possible. And just some of the stats around having a doula: less likely to need Pitocin, less likely to have a cesarean birth, less likely to use any pain medication at all, and more likely to rate their childbirth experience as positive. So, getting a doula in Iowa. Iowa's a little bit of a tricky state where there is no Medicaid coverage for doulas, but there's typically a whole lot of pilot programs that happen that are ran by hospitals, that are ran by the state, and individual organizations like the Collective. So on average, doulas charge here about $800 to $1,500, which I know in other states would be like no one showing up for that birth, like in Seattle. But in Iowa, those are good rates. Doulas are not covered by insurance at all here. So what we do within the collective that definitely makes us unique is that we have a My Doula Connect platform. And that means that a family could reach out and go to our website and say, hey, I'm looking for a doula. We have a portal that family goes into, there's an intake form, and they're immediately matched with families based on the need of the family and also the location. And so this makes it a seamless transaction for families to be able to get support. And then what also happens that within the system, they receive automated emails that gives them information like what to expect at your appointment, how to advocate for yourself, questions to ask your provider, nutrition guidelines, meal prep, all that kind of stuff. Okay, within the collective, we have 3 different types of doulas. We also have breastfeeding specialists. So all of our doulas are trained to support families with breastfeeding if the family is choosing to breastfeed. We have birth doulas, which that is the majority of the doulas in our collective. We have postpartum doulas, and we have bereavement doulas, which are new to the collective for this year because we saw the need in Iowa and decided that we needed to address some of the losses that were happening. And then here below, you see the definition of each doula. We do have crossover, so sometimes the birth doula is also a postpartum doula and is able to service that family for an extended amount of time. So why doulas are essential? Because Black women are 36% more likely to have a C-section than any other race based off of a 2022 study. And so because we know that doulas help support the C-section rate being lowered, they're essential. C-sections are, of course, a major surgery. So impact of our training. Based off of all the doulas that are in the state of Iowa, we have trained over 70% of those doulas. So whether they are still part of the collective or not, we've trained the vast majority of doulas within the state of Iowa. So that's with birth doulas, that's with postpartum doulas, as well as bereavement doulas. So this is the way that we show impact within the state of Iowa. So far, we've trained 77 doulas in the 4 years that the collective has been established. Each doula is required to become certified. You need 3 births to become certified. Simple math means that 230 families have the potential to be impacted by doula services. And it also means that we have 77 Black woman-owned businesses within the state of Iowa. I don't know if there's any other organization that can say that they've done that work at all. So our goal is by 2025 to have trained 100 Black women within the state. And that's birth doulas, that's postpartum doulas, and bereavement doulas, a combination of all of them. Expanding our community. So when the collective was established, we were serving only Black birthing families. The collective is all about adjusting and being able to accommodate what is actually needed within the state. So we are now officially a BIPOC organization, which means that we train BIPOC doulas and we also support BIPOC families. We will have our first official BIPOC training in October, and I'm really excited about that. We're also supporting families virtually and in person, and we have funds already secured to support up to 30 families per year for the next 2 years. Year to date, we've served 60 families. So we've definitely exceeded our goal of 30 families. And this is a combination of scholarship funds. I think that there's kind of a misstep where there's an assumption that when a family is needing a doula that they can't afford to pay. And that's not always the case. So that's a question that's asked on our intake form. Do you have financial resources to obtain a doula? And if the answer is yes, then the family pays out of pocket. If the answer is no, the family is able to receive a scholarship. And that can be a partial scholarship or a full scholarship. But I think that we do families a disservice by just making the assumption that it's not affordable for them. What the collective offers. I like to say that the collective is a sisterhood. We offer a lot networking opportunities. We do a lot of community service within the work throughout the entire state, making sure that we are doing continuing education. So it is not simply just a weekend doula training. There's business mentorship. There's what would be the equivalent to like spinning babies, which is fetal positioning training. We do implicit bias. We do domestic violence training. We have monthly meetings to make sure that the doulas are staying on par with what's going on in the state, making sure that their skills are always sharp, and that if there's a need within our community of doulas, that we're able to address those needs. So again, this is some of the education that we do. I am real big on education. I feel like everyone needs to be a continuous learner, and not one person knows everything. And so by working together, we definitely learn from each other and also learn from other organizations that we partner with. Our programs, I am really proud of our programs. We have a mom support group where we have a licensed trauma therapist that is Black that hosts these groups every other week. The turnout of these groups is phenomenal. She has journal prompts. We do giveaways in the groups, and it's really accessible because it's virtual. We also have Lachey, which is our breastfeeding support group that is also led by a Black IBCLC. It's also virtual. There we talk about weaning, depending on where someone is at in the stage of breastfeeding. We talk about the fears that people have with breastfeeding. There's a lot of myths out there of what happens to your body with breastfeeding. So it's also a well-attended group. All right, on the horizon for IBDC. Like I said, we have our first ever BIPOC doula training that will happen actually here in Des Moines. We also are taking a trip to Ghana. We have several doulas from multiple organizations that will be going to Ghana next month, actually, where we will be doing teaching comfort measures. We're going to be meeting with clinics and hospitals there and providers to learn traditional practices to be able to bring back here, as well as going to an orphanage. We've collected donations of shoes, coloring books, things like that, to offer to the people in Ghana, to the families in Ghana. It's going to be really exciting. So if you want to see what's happening, we'll definitely have it up on our social media platforms. We're also expanding our doula offerings, which is awesome, where we'll be doing placenta encapsulation. We have several doulas who are going to be trained in belly binding, which is a service that families have been requesting, and we didn't have the training here. So we have some doulas who will be going to Atlanta to take on that training in the coming year. And if anyone has any questions? And then here, there's a QR code for our newsletter. If you would like to stay up to date with what we're doing, we have a monthly newsletter that comes out. If anyone is ever wanting to make donations, organizations, we have a link to donations on our website as well. Or if you're interested in becoming a doula, there is a link on our website to sign up for our trainings as well. Do you still have space available in October training? We do. Yep, we have 2 spaces left in our October training. We try to make sure that we keep the trainings to 10 or less, because it can become really overwhelming. A lot of different personalities.
And how do one apply for one of those spots?
On our website, it's also on our Facebook page, our Instagram page, there's a link to an application. We do informational calls. I think that people need to understand what they're signing up for. So oftentimes people are like, oh yes, I want to be a doula because I saw something on TikTok or I saw something in a movie. Grey's Anatomy was talking about having a doula, right? And it seems really cool. You just go to this person's birth and you get to see this baby being born. And I'm like, yeah, but you don't see the behind the scenes work, right? Like you don't see the abusive relationships. You don't see the violence from providers. You don't see the families who are terrified to show up at the hospital because they don't know what the outcome is going to be. And so we do a lot of front end work. That is where actually majority of the work is done. I would say that the birth is probably the easy part. And then also managing the postpartum side. Big on the postpartum side, what does it look like for your village to show up for you? And your village could be a church member, family, neighbors, but no one is intended to raise a child on their own. And so you have to make sure that you have your village and that they know how to show up for you.
Is it on?
Uh-oh.
Do your bereavement doulas strictly work with like infant and child loss, or do they go outside of that?
Oh yeah, none of the bereavement doulas are just bereavement doulas. That was a training that we added on this year because unfortunately we had a lot of families who experienced losses and we didn't have enough resources. We just didn't, but they're not. All of our bereavement doulas are also birth doulas as well.
Do we have any other questions from folks in the room for Ebony? Oh.
Hey, Ebony. I'm just curious. A lot of doula conversations always talk about like kind of ways to improve the ways that states are going about reimbursing doulas and Medicaid reimbursement for doulas. In your ideal world, what would be like your dream of like how that could potentially work for Iowa?
Oh, that's an easy question. I got a whole plan, so if somebody want to write this down and let the state know, like this is what needs to happen. I'm just joking. But in an ideal world, doulas would be extremely accessible, right? Like there wouldn't be this barrier to who we could serve. I would say the vast majority of our doulas work a traditional 9-to-5 job because they cannot make a sustainable wage. And there's a balance between, okay, I want to just be a doula full time. What does that mean for your household? Does that mean that you now need to take on 5 clients a month? And so now there's no relationship with your family, with your kids, you're always gone. So it needs to be realistic. In an ideal world, it would be $1,500 to $2,000 per birth that the state would be reimbursing or Medicaid would be reimbursing. And that there would be some parameters around support for doulas. The secondary trauma is real. To see someone lose their baby, to see someone be abused by a provider, it's not something that's easily managed. So I also think that doulas need to have resources or access to mental health services. I think that's key. It prevents burnout. And when you have a network of people that you can go to who understand what you do, it makes a world of difference. So definitely good pay, making sure that there is resources to mental health for doulas for sure, and that if a doula is ever in need, that they have someone who can help uplift them and get them through hard times. Any more questions?
Any other questions? All right, well, I think that's it. Thank
All
you
right,
so
thank
much,
you.
Ebony.
Thanks so much, Ebony, for sharing all of that. My name's Elon Kotler. I'm one of the board members at March for Moms, and I'm going to introduce our next speaker. Martha Rivera is a traditional health worker birth doula, executive director of the Oregon Doula Association, and co-founder and director of the Doula Training Center. She's the granddaughter of a midwife, a daughter of immigrant parents, and a mother of 2 daughters. And she brings 16 years of dedicated experience in supporting families during their prenatal journey, as well as system and policy implementation relating to perinatal and reproductive health. She began her career as a maternal and child health care manager at FQHC, providing prenatal and childbirth education, referrals, and resources, and served as a liaison between the patient and their medical team. When she established her career in 2013, she led a county-wide cross-sector implementation of the One Key Question and assisted in the development of her region's first health equity coalition, So Health E. In 2016, she shifted her solo doula practice into a doula agency hub in Southern Oregon, making her the first to contract with a Medicaid plan in the state. Her commitment expands beyond helping families, and her focus for the last 6 years has been on workforce development, mentoring dozens of doulas, particularly through the traditional health worker doula pathway, which enables doulas to bill Medicaid in Oregon. And she also focuses on system adaptations to incorporate doulas while maintaining fidelity of the role. She's a co-founder and executive director of the Doula Training Center, which is an Oregon state-approved labor doula training. And most recently, she became the Oregon Doula Association's executive director after serving on the board for 6 years. And she also holds a position as commissioner on the Oregon Health Authority's Traditional Health Worker Commission, in which she advocates for fair doula practices, equitable compensation, and comprehensive training for traditional health worker doulas. Martha.
Hello, can you see me? Okay. Wow, hearing all of that, it's like, that's me. Where do I spend the free time of my life? Buenos días a todos. As mentioned, I'm Marta Rivera, a traditional health worker in the state of Oregon and the executive director of the Oregon Doula Association. And I am very excited to share with you about our state's approach, really Oregon Doula Association's approach, working with the state in doula integration. I'm going to start out with some fun facts just to get the jitters out of the way because I do get nervous speaking up here. But Oregon is comprised of 26 counties. We have Eastern Oregon, Central Oregon, Southern Oregon, the Oregon coast, which is beautiful, and then we have Portland. So if any of you have heard about Oregon, you probably have heard about Portland. Keep that in mind. We are the home of Tillamook cheese, which is amazing, beautiful factory. I haven't actually been there, but I plan to sometime. And we're also home to the deepest lake in the United States at nearly 2,000 feet deep. Crater Lake, if you're ever out there, please visit. It's gorgeous, and you can oftentimes find snow. I don't know if it snows here, but it definitely does over there. Not only that, it does, it snows. Okay, so never mind. Go when it doesn't snow. And not only that, but we are also the first state to integrate doula services into Medicaid. But it's been a long journey at that. But let's take a moment and just acknowledge that doulas have been a cultural practice that has been integrated in communities. This is a lifelong tradition. And now let's fast forward to 2011 when Ms. Shafia Monroe introduced House Bill 3311 to explore utilizing doulas to improve birth outcomes for underserved women or families in Oregon. It took several years, but in 2013, Oregon became the first state to designate birth doulas as eligible for Medicaid reimbursement. In response to that, the Oregon Doula Association was formed, predominantly being the voice of doulas, to advocate for sustainability, access, billing transparency, and workforce development. As you can see, these timelines, there's a lot of gaps in between. So a few years later, there was a billing pathway that was created after the Oregon Doula Association proposed some billing best practices that encouraged the state, or not encouraged, but made the state have us apply for an NPI number, a National Provider Identification, and also become Medicaid providers within the state. Then we also learned about codes and claims and all opened up a whole new world that, as doulas, we're here to support families. We're not here to fill out CMS 1500 forms, right? There was also an assessment. I think one of our previous presenters talked about how we need to ensure that the work that we're doing is actually working. And so this workforce assessment was completed in 2008, and we'll talk a little bit more about that. 2020 came around, and there was a push for coordinated care organizations. That's what we call them in Oregon, CCOs. There might be Medicaid, MCOs is another term I've used or heard in other places, but they mandated to establish provider contracts to provide access for traditional health workers. 2021 through 2022, we know COVID was really prominent in a lot of communities, and there was also a lot of changes that were happening in our state, especially with updating the Oregon administrative rules that reflected on, the doula traditional health worker pathways. And then here we are in 2022. Sometimes it's not what you know, it's who you know. We were sitting in a commission meeting, and we kept saying at every meeting, the rate increase is too low. The rates are too low. The rates are too low. And somebody in the meeting was like, what do you mean doulas are getting paid $350 for 4 visits and labor support and everything else that goes in between? We got to do something else about this. And it was one person from the state that really aligned with us, collaborated, and pushed this work forward. And so in 2022, we were able to increase that rate from $350 to $1,500 for that global rate. And just to tidbit more information, the initial reimbursement rate was set at $75. Yeah. And here we are. So a little bit about the traditional health workers. So the Oregon state approach is that doulas that are eligible to bill Medicaid need to go through the traditional health worker pathway. As you can see here, it looks like it's a pretty easy route, right? You take an OHA approved training, or if you've been trained as a doula prior to October of 2022, you can go through the legacy path. You complete those 3 births, postpartum visits, you submit your application, you apply for your NPI and your DMAP, you credential with coordinated care organizations or contract with them, and then you can bill Medicaid. Pretty straightforward, right? However, it takes time. It takes time. So you can see from the time, and some of this is dependent on the doula, how fast they can get through those births, how fast they're applying, for, submitting their application. But once those applications are in place, it takes time for those applications to be reviewed. And so all of this time, doulas have to, again, find somewhere else where they can, bring some income in, or sometimes they're doing volunteer work, or if there are funding available to support those doulas in the in-between until they're able to bill Medicaid, there's a big gap there. Not only that, doulas also need to have liability insurance, and then once the claim is submitted, once they're able to bill Medicaid, it can take 30 to 45 days, if not more, to be reimbursed. Along with the traditional health workers, these are the priority communities that were adopted by the Oregon Health Authority. And we know that congruent care is making sure that the families that are being served have a doula that speaks their language, somebody that matches their culture, or that has a lived experience that is shared. That is how we're able to better support these families. And we know this because Health Connect One put on their perinatal revolution report that when these services are performed by a culturally and linguistically matched doula, there is a reduction of health inequities by lowering incidences of trauma for both the birthing person and babies, as well as maternal and infant mortality rates. This extends into the postpartum period with less mood disorders and developmental or delay of chronic diseases. Reality, though, is that in Oregon, as of June of this year, we have 364 traditional health worker doulas registered in the state. Less than 10% are practicing outside of the Portland area. Remember Portland? This is why. Even less are practicing as traditional health worker doulas and or identify as BIPOC or multilingual. New doulas are feeling unequipped to support families, so shout out to Iowa Collective in supporting doulas after their training and providing mentorship, because a lot of doulas are feeling lost after that initial training. And we know that doulas have a shorter year span of practicing as doulas because there's such high demands. So here's some of the recommendations from the workforce assessment that was done in 2018. There's 15 recommendations that were pulled from this report. There will be a link where you can read the full report, but essentially, if you don't get through it, it's too long, you didn't read it, doulas are overworked and underpaid. And now a little introduction about our Oregon Doula Association team. So we have our board of directors, and then their executive director, and we also have a researcher. Looks like my lines didn't make it there, so apologize. All of the board of directors are doulas themselves. They're educators, they're advocates, they work within systems, policies, they're change agents. We are a member-based organization, so we have our board of directors, and then aside from that, we have various committees in which our members are encouraged to participate in. We have a membership committee, which ensures that our members are receiving the benefits of the organization and staying up to date with that. An education committee to ensure that there is clear communication being provided in regards to all of these components and changes that are happening from the state into the doula community. We have an elections committee. We hold elections every year. We also have a policy and advocacy committee, which is really active right now because we're getting ready to enter into legislation session in 2025. And then we have a conference that's happening. This is shamelessly making a plug. If you want to come visit Oregon, in Salem, we'll have our yearly conference this October. And our collaborative landscape, so we are really privileged in the sense that we work really closely with our Oregon Health Authority. They're the ones that are, saying that these are the rules, this is how things need to happen, but we are invited to come sit at the table and voice and advocate for doulas to ensure that there is equitable practices throughout any implementation that affects us. We work also with the various coordinated care organizations throughout our state. Each CCO works a little bit differently, and so we kind of bring in that, what can we keep consistent among all? Because we have doulas that sometimes are working with 3 or different coordinated care organizations, and there's different systems that they need to learn or work through. We have various doula training organizations that we work with as well. And then traditional health worker doulas, they are the reason why we're here. Not just THW doulas, we also have private practicing doulas in which we need to ensure that their practices are sustainable as well. And oftentimes, because the traditional health worker doula is a reflection of the communities they serve, they are consumers themselves. And we also work with doulas that are entering the workforce. Oftentimes, they're wanting to know, I want to be a doula. Where do I go? What trainings do I take? How do I get from point A to point B? A little bit more about our funding. So Oregon Doula Association has been in existence since 2013. And really, it has come from the board of directors, and not just the ones that are currently on the board, but the founders and everyone that has come through the organization these last 11 years now. But it's really been a volunteer position for a lot of this. A lot of this work has been moved because doulas on the board, folks on the board have been committed to seeing this change happen. It wasn't until last year when HealthShare, which is a coordinated care organization, reached out to us and said, we have funding and we want to give it to your organization. We see the work that you've been doing. How can we expand on that? So last year we received $500,000 to fund the Oregon Doula Association, bringing it into 2 buckets. So one of them is to build the capacity within our organization, which enabled for me to be in this position. We're also looking to hire a program assistant, and we have contracted with a researcher that is going to support a lot of the work to ensure that we're, staying in course with what needs to happen. It's going to fund our conferences as well. And then on the other side, we have doula awareness. So Portland Metro is our focus. That's where that CCO is located. So we're in year 1 and 2, that's where our focus area is going to be. And then we can expand beyond that area in supporting doulas outside. And with that, we are able to provide assistance for traditional health worker designation. So we have open technical assistant hours where doulas can register for, and then I'm guiding them through that process. So whether they're looking at the application for the first time or they run into billing issues, then we can troubleshoot those together. Aside from that is we know that there are already communities that are providing mentorship within the state of Oregon. So instead of us taking that funding and duplicating those efforts, we're really investing in those communities so that they can continue doing the mentorship that they're already knowing how to do. I'm located in Medford. I'm on the opposite side of Portland, so I'm near Northern California border. And even though I'm a doula in the state of Oregon, I know Portland Metro looks really different than Southern Oregon. And so I can provide some general assistance, but really supporting those communities is going to allow that work to be more meaningful and more mirror, those communities that they're serving. Part of her research is also doing some listening sessions. So Katie Minich is one of our researchers that we have on the team, and I love her style. Just shout out, I know you're watching me, Katie. She's virtual. But her style is really bringing Indigenous practices into this and allowing people to share their stories in a very kind way. And I will say I've participated, I'm self-disclosing, I participated in some of her research, and it brings some type of healing, because when we share our stories, we find solidarity within our communities, even if we have different views of how we practice as doulas, of how we create businesses, of how we push this work forward, of how we advocate. We're still doulas, and that's our commonality. This is some of the past work that the Oregon Doula Association has done in regards to policy. So again, looking at that workforce assessment, it was an interview of doulas in the state, not just doulas, but also providers and consumers. And we were able to identify trends and barriers, opportunities, and opportunities for success. Provided that billing guide for doulas, and also we were really loud when the COVID restrictions came about. You know, doulas were not allowed to be in the birth spaces, and that was not fair. We are a workforce. We should be respected as a provider of the families that we're serving. So while the state did receive some of our recommendations, they only restricted it to, or unrestricted traditional health worker doulas, as opposed to any doula that was practicing in their communities. Lots of work around the Oregon administrative rules. So there were the state implemented some rules that, in order to become traditional health worker doulas, or how to practice as doulas. And so some of them were creating some challenges and barriers for families to have access to doulas. One of them primarily being that doulas needed to have a referral from an OB provider in order to render services to a family. Why? That's not necessary, right? Clients should be able to choose if they want to work with a doula. We don't need to have a provider saying, yes, you can have a doula. That is limiting, and we were able to advocate to remove that from the rules. And then influencing the doula training requirements as well. And I want to say this because sometimes other states look at us and be like, oh, they're only choosing certain organizations. But what was shared from the state, and I say this because we work closely with them, is that in order, we are traditional health worker doulas. We know that trainings are very different. We have a 2-day training, we have a 3-day training, we have a 10-day training, 8 weeks, etc. And there wasn't consistency. And so in order for traditional health workers, in order for there to be some consistency around the support that families are receiving, there needed to be some consistency in the trainings that doulas were receiving. Aside from having the core components of a doula training, traditional health worker doulas also have to take 4 hours of trauma-informed care. 4 hours of cultural competency training, or 6 hours, I think it's 6 actually, 2 hours of interprofessional collaboration, and an oral health training. Oral health, it was slipped in there. We talk about dental health. Go visit your dentist, I guess. So those were some of the requirements that are additional from the core curriculum of being a doula. But not only that, let's talk about how doulas care for themselves. We talk about that secondary trauma. How do we fill our cup so that we can continue to support our families? So self-care is really important. I like to use the term self-maintenance, because self-care kind of implies like, oh, I have my Starbucks coffee, I got my nails done, we're good to go, right? But it's really maintaining ourselves. I think about it as a car. We need gas every so often. We need to change our oil every so often. Maybe we need to change our tires. And so looking at ourselves as how do we maintain, what do we need? And not just in the day-to-day, but long-term. How are we caring for ourselves? How is our community caring for ourselves? And how are these systems and structural spaces caring for us as doulas, as carers for others? Did I cover everything? Yeah. Our present policy work, so this we're really excited for. We have been pushing this one-pager. You can read more about it on our website as well, but it's to expand the reimbursement for traditional health workers' birth billing. So as I mentioned, our global package, what is considered our global package is 4 visits, so 2 prenatal visits, labor support, and 2 postpartum visits. But we know as community doulas, we are providing a lot more support outside of those 4 visits, right? Oftentimes we're meeting with families for more than 4 visits, and we are not being compensated for that. So how can we expand so that if families do need more support, do need more visits, that doulas are also being compensated for that work? Aside from that is adding postpartum doulas as a new traditional health worker Medicaid provider type. And so this has kind of been an ongoing conversation with the state right now, because they're like, well, doulas can do postpartum work, but I will tell you, I'm a birth doula, I don't do postpartum. And I don't want to do postpartum. And I've heard the same from postpartum doulas. They're like, yeah, I don't step foot in a birth space. Like, I stick with families postpartum, and that's what I do. And so that also, creating a separate pathway for postpartum doulas also allows us to maintain fidelity of the role. And I speak about fidelity of the role because oftentimes doulas are looked at as like the catch-all. We can be a nutritionist, we can be a mental health therapist, we can be childcare, we can be all of these things for families. And yet we work in a very limited scope of practice oftentimes, and we're not necessarily always respected for the work that we do. So how are we expected to fulfill all of these things, right? And then continue to fund traditional health worker birth and postpartum doula workforce diversity and development. So again, there is a gap between becoming a doula and being able to bill Medicaid. So how are we supporting doulas during those pieces? And really focusing on the community-based organizations that are rooting cultural and linguistically diverse doulas to create access. Because we know, as I shared, the reality is that the program is not looking like it was meant to look, right? And then, of course, the fourth part of our policy work is to mandate commercial insurances to add birth and postpartum doula services to their benefits. Doula access doesn't just mean for Medicaid families, it means for all families, right? And so we need to ensure that all insurances are covering for doula services to increase that access. And you'll see that I have 2 starred, and I'm really excited to share that we've have received news from the state from that point 1, they are actually expanding the doula benefit visits, so they're increasing up to 8 that can be used flexibly. So they're still wanting to maintain those 2 and 4, but an additional 4 visits can be used in either way, and it sounds like that may be implemented in 2025. And then on point number 4, we have one commercial plan that is starting slow, or not slow, small, but they are going to be adding doula coverage benefits for their public health and educational employees. So those are 2 pieces where we're like, we need to push forward, and they heard, and we're moving along with that. Over the next 3 years, based on the grant that we received, we want to go back to that drawing board. Does our organization have equitable representation? We know that doulas come and go. There's new players that are emerging. People are moving into Oregon from other states that have experience. How can we really create that cohesive collaboration amongst all doulas? Because again, that is where we come together. Identify those gaps. We know that in Oregon, there are pockets of really thriving organizations and doula communities, but we also know that in our rural communities, that doesn't look the same, right? And so how do we allocate some of the funding that is coming through the state to those areas to ensure that access is being provided throughout the entire state and not just in those hot pockets of area? And create a state map. I'm a very visual person, so I'm already picturing like the state of Oregon and then all of these like little hot spots, right? To not only share where you can access a doula, but where those doula training trainings are being held. Right now, there's one in Southern Oregon, which is the one we have, and then there's lots in Portland. So again, Portland. I love you, Portland folks. What's the current doula landscape? So I love that in these conversations and in these presentations that we've heard, we talk about doulas needing support, right? So doulas often are practicing either as an individual doula. They may be having another doula that they're working with for backup support. They may be integrated into a doula hub or working within a hospital system. But regardless of where this doula falls in those categories or how they're implementing their practices, they need support too. So how can we create those networks for doulas to feel comfortable? There is this thing about competition. Okay, great, we're all here because we want families, we want to serve, but again, let's bring it back to why we're here. We're here to serve families, and if we can get beyond that, then we can make change happen. Our recommendations is funding for community-based organizations. So some of these recommendations are still from that 2018 workforce needs assessment. So some things have changed and some things we still need to keep pushing for. So we know community-based organizations need to have administrative staffing, right? If you want to be a doula, you need to serve families, but then you also have your stack of paperwork over here in order to submit claims. So how do we invest in these community-based organizations so it removes some of that administrative burden for the doulas to be able to fully focus on supporting families. Community-based organizations are also the ones communicating out to other providers, to hospitals within their communities. This is what's happening. These are the services that we can provide to your families. And they're providing wraparound services. So it's not just about, let's talk about your birth plan, but do you have access to food? Do you have transportation? How can we get you, diapers or baby clothes, whatever that may be, a car seat? There's more that goes into the work that we do as community doulas. And they also integrate mentorship and peer review. So in our state, we're looking at, the Oregon Health Authority is looking at exploring supervision for traditional health workers. And traditional health workers, are not just doulas, but they're community health workers, they're their peers, they're family support specialists, but we need that support for ourselves as well. Enhancing our Medicaid billing for services provided outside of those current visits, especially those addressing social determinants of health. So yay, Oregon, we increased up to 8 visits, and oftentimes, a lot of the work happens outside of prenatal and postpartum visits. There's care coordination that goes along with that. We're calling other organizations sometimes on behalf of clients. We're assisting them in other ways that fall outside of those visits. So how are we able to address that and also be compensated for that? And create communication pathways. So make those one-pagers, call to actions, provide educational tools for doulas, providers, and consumers. This helps raise awareness. Not only that, but it also creates a clear communication. We know that when a lot of the work was happening, and only I experienced this myself as a new doula wanting to become a traditional health worker or bill Medicaid, I was told, oh, you just get on the registry and you can bill Medicaid. I'm like, cool, I can do that. So I did. And then I redid my whole marketing and I put everywhere, I can take OHP, I can take Oregon Health Plan, I can take OHP, and then they're like, oh no, you have to do this, 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 and this. And I'm like, oh my gosh, I was not ready. But there wasn't clear communication for me to know that. So anyway, create those one-pagers, call to action, those educational tools, and ultimately, nothing about us without us. Your voice is powerful. Doulas need to be in these spaces talking about what our needs are, right? We can't have, sorry if your name is Sally, but I'm going to use you as an example. Can't have Sally over here saying, oh, I think doulas need, a brand new car and, I don't know, unlimited coffee. Yes, we do need unlimited coffee or tea or whatever your beverage choice is. But if we are not there voicing what our needs are, then it's not going to help us. So get in those spaces. You belong at the table. Get out there. And for folks that are not doulas, please invite your doulas into the conversation. And it's a ripple effect. So as you can see, I'm not talking much about how we are supporting families directly, right? But we are supporting doulas, and supporting doulas is supporting families. So we need to ensure that our practices are equitable, that trainings are comprehensive to support this emerging workforce, that if there is a state certification pathway, that it's clear, that is not full of challenges and barriers, because that is what is going to limit us in supporting families, that billing processes are fair, right? That reimbursement is a true reimbursement of the work that we are doing and more. And that doula hubs are also implemented in equitable ways that are supporting families and the needs of the community. And here is a cute little QR code. You can scan it if you'd like, and there is a page with a bunch of different links on there, and my email is there, so if you have any other, want to connect later, then I'm happy to do so, and I'll open it up for questions.
Ooh, we do have a question. Can you talk more about the advocacy strategies that you all may have used to increase the reimbursement rates from $350 to $1,500?
Yes, so as mentioned, I am also on the Traditional Health Worker Commission, and a lot of our board members also participate in those meetings as public. And so that is a space where we are able to come into and talk about these concerns that we have. And so as I mentioned, we got pretty lucky on that one because there was somebody that worked in another division within the state and was like, what do you mean? Let me explore this. And so it did, take several months, and we did have one of their medical directors reach out and say, okay, tell me exactly what is it that doulas do? Why are you asking for more than $350? And let's also, I'm going to point out also that a lot of times doulas come into this because it's heart work, right? But it's hard work. And if we are looking at doing a market analysis and we have doulas that are volunteering, and I mean truly volunteering, they're not receiving any type of stipends or anything like that, and then we have doulas charging $2,500 for services, when folks are looking at that, they're like, oh, well, doulas are doing this for free, so $350 is totally reasonable, right? So not to say anything about whether you charge or not for your services, but keep those things in mind, that when you put value into the work that we do, other people will start recognizing that as well.
Do we have any questions from folks in the room? I think that was it from the chat so far.
Hi, thank you for sharing your knowledge. My name's Bree. I'm a women's health nurse practitioner. And so coming from a labor and delivery nurse background and really wanting to better support and have services such as yours available to patients, when you mention this, I don't want to assume, so I'm going to ask. I imagine it's state dependent, right, on reimbursement, is that correct? Similar to nurse practitioners or midwives, it varies by state. How well we're supported oftentimes. Have you ran into the same thing?
It does seem like it's state dependent. So Oregon is currently at $1,500. There are other states that are implementing or having Medicaid covered services that have different compensation rates, but they also have different requirements or billable visits that they can. So when you're looking at, we take our global package as $1,500, that's 4 visits, and labor support. You may have another state that is providing a higher reimbursement rate, but they also have more visits for that. So when you break down the numbers, it really doesn't look much different.
It doesn't, okay.
Yeah.
And then just a follow-up question for individuals, say, in my type role, and being very open and wanting my patients to have this as an option. When you have worked with individuals such as myself or other types of nurses, what's ideal, right? Like, how could we best partner or support what you're doing?
I love that. Plant the seed with the birth team, and that is across the birth centers, because you might have a nurse that is a champion for doulas, you may have a provider that is a champion for doulas, but we're not guaranteed to always work with that provider or with that nurse. So making a cultural shift within your organization to ensure that doulas are welcomed into the, not just welcome, but integrated. And that may mean, and I will share from experience, I worked at a hospital as a staff doula, and it was a beautiful dance. I knew my nurses, and oh, Kim over here, you like to stand on the left, I'll go stand on the right, no worries, right? Oh, my client needs a warm blanket, I can go and get one, so I'm not bothering the nurse because she has like 10 other patients she's charting with. So giving access to these things that doulas are really there to support, not just families, right? But we're also there to support the other birth team, because if I can go out to the kitchen and grab some ice chips, that allows the nurse to really focus on other things as well. And I know that nurses, they're like, but that takes away what I want to do. And sometimes that is, but how can we work together? Because we're here for that birthing family. And if it's the space in birth, and for all of you that are birth doulas or have been to births, you know that energy can be felt one way or another. So if there is tension between a doula and that provider or that nurse, that is ultimately going to affect that client. So why are we here? Why are we in these birth spaces if it's not to honor the families that we're serving? Thank you.
Any other questions from folks in the room?
Hi. Oh my gosh, it's very weird to talk into a microphone.
Right?
I feel like I might have an understanding of this, but you've made a bit of a delineation between doulas and traditional health worker doulas, and I was wondering if you could speak to that a little bit. And I also had a second question about if you all have any coverage for virtual, like over the phone or over like Zoom or something visits, or if it's only in person.
Yeah, so I'll answer your second question. So some coordinated care organizations do still allow virtual visits for doulas, and this was kind of a residue from the COVID that a lot of our visits moved virtually, but some of them are saying like, nope, we got to get back into people's, spaces. So it's dependent on coordinated care organizations. And then the difference between traditional health worker doulas and just doulas in the community is the ability to bill Medicaid. A lot of doulas may choose to not go that route just because it is burdensome, right? But they can still very much be community-based. And so that's really the differentiation, I would say, between both roles, is that ability to bill Medicaid.
Any other questions?
So when you talk about the ability to bill Medicaid, is that through an agency or is that a direct Medicaid billing as a provider?
Yeah, so doulas can bill independently to the coordinated care organizations or to the state OHA. Some doulas choose to work with doula hubs, and the doula hub may take care of all of those billing aspects. There are also only like billing, so hubs can work a little bit differently. So when I used to run a doula hub, it was a full service hub or agency, which we did all of the marketing, we did all of the networking, all of the pieces, so the doulas really just were able to be a doula. There are some doula hubs that each doula still kind of works independently, but they may submit, certain information for those claims to be filled. So it really just depends on the structure of the organization and how doulas want to integrate themselves into those pieces. Yeah.
Any others? All right. Well, thank you so much for being here with us today, Martha. So we're going to go ahead and take a quick 10-minute break to give you guys some time to grab some breakfast, use the restroom. So for our virtual attendees, we'll be back in 10 minutes. Thank you. All right, welcome back, everyone, and to our virtual attendees. I'm Lanicia Rest, Executive Director of March for Moms. Just wanted to reintroduce myself, but I also have the pleasure of introducing our new speaker, who is a team member of our presenting sponsor, Argonon. Bree Harbin, DNP, WHNPBC, is a dedicated women's health professional with 25 years of experience in medicine, specializing in women's health. She currently serves as the Medical Director, Medical Science Liaison for Argonon, a women's healthcare global medical organization. Previously, Bree worked as a women's health nurse practitioner in an OBGYN setting, specializing in gynecology, contraception, and menopause. Let's welcome Bree.
Thank you all. I'm happy to be here, especially after many delays. It all worked out. Someone was looking out for us. But it's been a pleasure to get to know the team of March for Moms. And as was shared, I am a women's health nurse practitioner by trade. I was a labor and delivery nurse and then worked in a private OBGYN office. I'm from Indiana, which, like the state that we're in, is under a lot of reproductive challenges at the current time. And so I want to share with all of you, I'm currently a medical director for Argonon. Nothing that we do today is to promote products or to do anything commercial-based. I share with you my current role as a director when I'm not in settings like this is to meet with leaders and women's health advocates across the country and help to better identify gaps. And it could be gaps in the sciences and daily practices for things of gynecology with contraception. We're branching into menopause with maternal health, specifically on postpartum hemorrhage. And we're also getting into bone health and have many other areas that we're interested in. But my main focus is today to, one, pause and say thank you, right? That we're all able to meet together, that we're all able to work and take action in making the lives of women and their families across many states and our nation better. And I know in Iowa things are rough currently politically. I want to pause and acknowledge that. I fight the same issues day to day in my state of Indiana, and I hope that we all feel encouraged, and I'll take some words that inspired me this week, that it's time that we do something. And I think it's meetings like this that we're able to do something, right? And so whether it's we take one bullet point from one another, whether it's we recharge and come out stronger with motivation. And I love the acknowledgement of not self-care, but really taking care of ourselves to keep our tenacity up, because now's the time we have to go forward with vengeance, right? Kind expertise that we all do. So in this 1 hour, it was going to be over lunch, but I know we're running a little bit ahead. I really don't want to lecture to you guys. I have slides, but it's really meant to be interactive, right? How can we better work sharing challenges that we face? And although my topic might seem that it's not extremely relevant at first, I think if we take a moment to step back, the focus, yes, may be on contraception with person-centered care or patient-centered care, but I think all of us, whether we're doulas, whether we're traditional maternal health workers, whether we're nurses, whether we're patient advocates, whether we ourselves identify as women or there's women that we love, we all can help empower women to make better choices and know that they're informed when they're preparing for an office visit, when they're in front of a healthcare provider, and just as we were discussing, when they go home, so that they can better take care of themselves and their families. So when I say that, when I ask for interaction, I really do mean it. You know, interrupt me at any point. I'm lucky to have a recent friend that we graduated together with our doctorate program. And those of you that I've gotten to know, and I hope as we get to mingle today, I'm very informal, right? I really want it to be interactive. My goal is, one, to meet all of you, selfishly, to leave and feel recharged when I go back in to see the people that I interact with every day, but also for you to leave with one nugget, right? Even if there's just one piece of information that speaks to you or that you can pay it forward. So with that being said, any questions about my background or what we're hoping to do? And for those of you watching at home, I promise I will give you all my contact information at the end so you can reach out to me as well. Okay. So if we go forward, you'll see this is a medical slide deck, right? So it is from my company, but it's based on a contraceptive counseling platform. And again, contraception is one of my passions, right, across the entire lifespan. When I refer to a woman, I want to be very inclusive and say that's individuals born as women, individuals that identify as women, but I think it's also important that even if you are not born a woman or don't identify with a woman, I know there's a woman in your life that you care about. So this is relevant for all of us. And if you can go forward on the slides, please. Thank you so much. So we'll talk through each of these things. There's a specific contraceptive platform that is a shared decision-making platform that we'll go through. We'll talk about some specific tools that are recognized by the WHO and other professional associations, as well as, it's not real fancy, but I even have a list of resources that I use. Some of us were talking about referral sheets or our little go-to books that we can call on when we see individuals in need, and I will provide those to those of you in the room today for you to learn more about and also have them available to share with those listening in. We'll talk about how to best use the shared decision-making process, and then there's additional considerations. And this is the part I think will be really interactive, where we talk about some special populations, whether those be adolescents, those with limited or difficulties and mental health impairments and or substance abuse for a few categories. Next slide, please. So let's get into the background. We can go forward. Thank you. So contraceptive counseling, this sounds kind of obvious, but it's defined as a process that enables patients to make and follow through on decisions about their contraceptive use. And a few components of this process include the following. And this is where I think those of us that are traditional maternal health workers, right, maybe NPs, certified nurse midwives that have prescriptive privileges, but also those that may be nurses, those that are doulas in this room, we all know the importance of establishing rapport and trust, right? This is something that I think I could even up my ante from all of you in this room as doulas. And so when I ask questions, it's because I've always really admired the experiences I've had in witnessing that. So some of us, and all of us, can better help prepare not only the patient, but her family and loved ones for the counseling. We can establish rapport each and every interaction. And I know some of us ask about virtual visits versus those in person. I believe rapport can be established through a computer, right? We've all gotten good at it through FaceTime. It can be established through a phone call, and it can be established through our actions and our words in person as well. The counseling also involves obtaining clinical and social information, which can be collected from traditional providers again, or those non-traditional, and working interactively to select an effective and appropriate method. Even just in our one-side 10-minute talk during the break, I think this is really important. So shared decision-making and patient empowerment takes place in no matter what type of interaction we have, right? That's what we're all after. And I think that's where our whole country, those of us in this room, really want to see things go. So this is all focused on, we are a team. Even though we come in with a level of expertise, our job is not to say what we think's best, but to help a female or a patient and their family decides what's best for them. And I think that's a key takeaway that we can continue to do so with vigor when we leave this room. The importance of conducting physical exams when warranted for contraception use. And another key takeaway that all of us can utilize is providing the instructions for use and the follow-up plan, right? That's so important, whether it's in person, whether it's virtual, whether it's a touch-based phone call, whether it's through the utilization of tools and apps that are taking more and more place, right, and individuals are using. And the ever so important confirming understanding by the individual in front of us. And we'll talk about some tactics. It sounds so simple, but things like the teach back method are having them relay back to us what we think we've explained so well, right? If we don't confirm that it's understood, we could do the best of our ability, but if the person leaving doesn't understand, we've missed the boat. Any questions so far, or anything that speaks out to any of you? Not yet? Okay, go forward, please. So this goes a little bit more into the preparation, right? Why is this important? Anytime we prepare for a visit, no matter what type it is, it helps us better plan, better adapt, and be more open to what presents, right? We can plan all day long, but if we're not comfortable in what we hope to achieve and don't have a shared outcome goal with the individual sitting before us, none of it matters. We need to make sure it's relevant. So decision support tools help to improve the quality of contraceptive counseling, yes, but let's be honest, they help to improve the quality of any type of interaction, right? Whether it be a prenatal visit, whether it be a mental health assessment, a nutrition visit, a postpartum check, it's relevant no matter what. A decision tool can help, it states here, women identify their preferences and compare methods, but I've also had many great interactions where I involve not only the patient, but if she has a supportive loved one with her or a friend, because in many cultures, and all of us, no matter our culture or background, knowing that our loved ones are beside us and they too understand, it's important. Support matters. And this information can then be communicated to the patient's HCP, whether they be there with you or they can prepare an individual for when they go later to meet with their HCP so that they have questions in mind, they feel confident in the information they should be receiving, and they're also more likely to use their voice if things aren't going well to make them feel safe or respected. There's a little note here that I think absent online information, there's an abundance of things, right? Whether it be for contraception, and I would add a little tidbit here. Many providers, and we talk about closed-mindedness, right? Many providers are sometimes closed-minded to gathering others' opinions. And I think it's really important that we stress to individuals, and even we model this, that when someone comes to you with information, whether they saw it on TikTok, whether they saw it on Instagram, whether they heard it from their best friend, we validate that. Right? That's that establishing trust. If we just dismiss that, how likely is that individual to come to us with other things? They need to feel that we hear them. And maybe it isn't accurate information, but how about if we use that as a moment to establish trust so that they feel comfortable coming to us next time, and we can set the information straight right there. And then they're more likely to reach back. But I think that's important. I also think as providers and with experts, we also have an obligation, and I'll be honest, I'm probably older than a lot of you in this room. Social media is not really my jam, right? It's not where I've thought in my comfort in growing up of where to share medical information, but I need to be current, right? And if I have a problem with what's out there, I need to do something, right? To borrow that again. Then am I using my agency to put out accurate information? And it is outside my comfort zone, right? I don't know whose toes I'm gonna step on. It takes time when we're all short of time. It takes effort. But if we're not doing something even small to move the needle, we can't get frustrated. So I think that's a way, even today, if you see something that upsets you, I have to remind myself too, it's not always easy, then what am I doing? What can I do to help? So I just have to add that in. We talked about why a platform is needed, and it can make a significant impact in women achieving their reproductive goals. Components can include such things as society-based guidelines, whether it's through midwifery guidelines, the American College of Obstetrics and Gynecology. I'm going to call on some of my peers. I learned from you already today and from talking, there's associations and support for doulas, right? That we can all come together. And more of us that collaborate, the stronger these platforms become. And I think that's very, very important. I'll share some of my favorites, in the little resource list, but I think be open to experts from other areas as well. And I think, again, if we take time to pause in states where I hear of difficulty, and I'll use my home state of Indiana. When I hear of challenges, individuals are more and more apprehensive to go to providers, right? They're more apprehensive to seek out questions. And so these platforms enable open discussion. They enable them to feel that their voice matters and to bring questions, to establish that trust. So there's not hesitancy. And it's proven more and more in the literature and evidence-based data, women and their families are going to more and more non-traditional healthcare providers each and every day. And so, in the past, they only came to individuals like myself when I was in practice, right? Everybody went to their OBGYN or a women's health clinic. Those aren't available to many. And so individuals may be seeking their contraceptive care, their maternal health care, wherever they can meet it and or where that trust is established. And so I shared, and it's relevant, I wasn't planning this, but, dream big. How beautiful, we were saying, would it be if we had a hospital that had someone readily available from a doula service that could call on a midwife, could call on the counseling and the services. But it takes us using our voice and our agency to show what services we provide and to make sure that they're readily available to those seeking them. And this talks about the human rights principles, which is what this leads into. And this might be where some of you can share things, so please do. All counseling platforms should be based on human principles. And it says contraception platforms, but if you go forward, I would be interested for your guys' thoughts, because these 9 human right principles, yes, they should be assumed, right? One of the first speakers today it should be assumed that someone always has to give you consent before we do something in medicine. Well, it doesn't always happen, right? So these are 9 human principles, and we'll talk about each of them, and you can see them here, but they're very important. And this is where I think each of us, when we talk about taking a step back each and every day, again, I'll use myself for example. I've been in practice for 25 years. So it's very easy, even though I'm passionate about it, I'm human, to sometimes go through my comfort, go through my patterns and routines. But if we step back and ask ourselves these principles, how can I ensure that this is non-discriminatory? How can I assure that this is the best quality of care? How can I assure that I'm being accountable to the individual in front of me? So let's go forward and see if any of you have ideas to offer. So this first one, again, we're good people in this room, right? I know from what you're passionate about and what you're taking time out of your day to do and what you do in the daily world. But it lists some things here. Welcome all patients equally, right? Respect every patient's needs and wishes. And I think this third bullet point, especially in this day and age, is we set aside our own personal judgments or our own personal beliefs and any negative opinions and recognize we don't know what the individual in front of us is going through. And so our job is to give them all options and let them choose what's best for them. So I'm not sure, when you guys read this, is there any example, and don't feel silly, I know sometimes it's hard to share, sometimes when it's more intimate, and maybe nothing comes to you, but I don't know if there's any examples that you guys can think of in something so small that you can ensure that you're doing this. Yes, please.
Have a seat, can I give you a water? Do you need anything? And then I was so mad in my, so because she dealing with her client differently, and that hurt me badly, and then I decided I'm not gonna be there anymore. So assume that it's just for a nail. We do that in helping in care session, it will be bad. So when you brought that,
Thank you for being brave to share. And thank you for using your agency to leave. And I think that's a beautiful example, right? We need to make sure that everyone feels safe and that they feel respected. Any other ideas on this one?
You talked about sharing information.
Yes.
Sometimes people think about sharing information as, I'm going to give you this sheet of paper and assume once that you can read, and two, that you can comprehend what you're reading. And so there has to be tools around different ways of communication and asking the right question to make sure that the patient understands, right? But that's also looking at the body language. If someone is just glazing over, they don't understand what you're saying 9 times out of 10. And so how are you, as you're presenting information, saying, hey, I wanted this patient to walk out of here, and if someone asks them how your appointment went, they can actually articulate what happened, what decisions were made, and why they were made.
And that's a beautiful explanation for somewhat like the teach-back method, right? When you look at, one, you have to establish they can read the materials. Are they age appropriate? Are they culturally appropriate? Are they open? Are they non-discriminatory? And the nonverbals, huge. In your expertise, and I'm going to pick on you because I know you're such a leader in this, what's an example of even one thing that you do to help with that? You said nonverbals and body language, I think, is huge. Do you do something like a teach-back method or have them?
So whenever I'm explaining something that I feel like may be easy or hard, that's relative to understand, I always say, okay, tell me what you heard, and then give me an example. Because what I said may not be what you received. And so now we've already had a miscommunication. If you thought I told you to go left and you were like, oh, no, I thought you said go down 2 blocks and then go left, right? And so I think that being able to have people kind of give an example of whatever you're explaining is also useful, because they'll remember their own example and not necessarily the one that you may have given them.
Thank you so much. Very good. Okay, let's go on to the next one. Thank you, guys. These are the things that I think, okay, you can take that with you, right? You can be reminded of that when you're driving down the car, when you're in the next interaction. So principle 2, availability of the contraceptive information and services. So know the family planning methods that are available, how to provide them. This is more of a processes, right? So this may not be extremely relevant for everyone in the room, but we could take it to other areas, which we'll do. Help make sure the supplies are in stock, and do not rule out any method for a patient, and do not hold back information. So that last bullet point, when I was preparing this, you know, sometimes when I've shared this, it's with contraception offices, right, or doctors' offices that have these things right in stock. But I think this goes to your point as well, and as we talk about openness, don't make assumptions. You know, don't stereotype. And I'll use an example to be vulnerable. When I was brand new as an NP, again, done with a good heart, many years ago, we were oftentimes taught certain methods were best for certain age groups, if I'm being very honest, right? And so even with the best intentions, if I saw I was seeing a 15 or 16-year-old, it took me getting more confident and me not having to have all the answers, and empower her to realize, don't make the assumption she's not responsible. Don't make the assumption she can't remember something every day. Talk to her about the pros and cons and let her make that choice, right? So that's an example that I can look back and I'm like, oh gosh, I thought I was doing a great job, but I could have done better, right? Anybody else have anything on this one? Some of them get a little bit easier to transfer to other things. Yeah.
Thank you. After giving birth to my second child, when I gave birth to her, I had my tubes removed. And when I went to my postpartum follow-up, the doctor, yes, she was an OB, essentially was like, oh, your tubes are gone, so we don't need to talk about birth control then. You know, and I can tell by your face, like, yeah, that's definitely not best practice. Yeah, she didn't ask me about like my periods, you know, like stuff like that. No, it kind of felt like the options were being held from me. So.
Thank you for sharing, and I'm sorry that. Thank you. We can go forward. I guess I could use my clicker. You've probably been wanting to tell me that, huh? Sorry, sir. Okay, I'll do better. He's probably like, ma'am. Microphone. I'll use the tip clicker so you don't have to do it for me. Thank you. So principle 3, accessible information and services. So our role, whether traditional or please share if you had something. Oh, okay, cool. I didn't want to cut you off. Thank you. So help make sure that everyone can use your facility, even if they have a physical disability. So this, I think we can all affirm too as well, right? Whether it's reading, whether it's sight, whether it's hearing, no matter what modality. And even if we are having someone meet us, are they able to? Can they walk comfortably? I think that's something to, not make assumptions. Participate in outreach when possible. The lovely individual before myself even mentioned this too. Be part of outreaches, go to community events, get your name out there, spread word of what we're doing. Do not ask patients, even young patients, to get someone else's permission to use family planning. And I think this is really important right now. State laws are changing all the time. It's hard to keep up with. I will be vulnerable and share with you, I'm raising a young daughter myself, and it is a beautiful thing to see from a young age that she is very proud and protective of her body, and even whether it's, giving hugs to who you want to give hugs to. I think little things like that change mind shifts, right, and cultural changes. They may seem small, but they're big. And I think the same thing that when you go into a situation and it doesn't feel good, leave, right? If you go to a provider and you don't feel like they listen to you or they're not honoring you, choose someone else, right? That's very important. Thank you very much. Any examples on this one? Yes. Of course.
There's a couple of things that I've had former clients run into as far as like accessibility issues in the medical setting. Something that people don't think about a lot is like having the ability to take someone from a wheelchair and get them up to that really high table in an OBGYN's office can be very difficult, if not impossible at times, and being ready for that. And also, there are hospitals, even locally, that will not allow you to have births there if you're over a certain BMI, even not really taking into account any other health inputs. And so there's a lot of room for accessibility growth locally and across the country, I think.
Thank you for sharing that. And that's a situation I was going to somewhat address in the special populations. Again, I'll speak to my knowledge in my area of expertise, where I'm really pushing for more and more research on contraception efficacy and safety in individuals that have either gone through gastric bypass and or in heavier body weight individuals, because I think they've been dismissed from a lot of clinical research studies, and we need to do better. So thank you for sharing that. And I think your point for myself, thinking back to practice and a few individuals that had to use wheelchairs and whatnot, many were very apprehensive, if not avoided visits because of the embarrassment or the awkwardness. And so I think more and more that we can soften that and make sure that we have services available and they are treated just like anyone else. It is so important. Thank you. So principle 4, acceptable information and services. So again, it sounds easy, but being friendly and welcoming and ensuring that our facility knows that's a priority. The second bullet is so important, putting ourselves in the patient's shoes and having empathy, even when we're burnout and fatigued. I strongly believe, and maybe it's my idealism, I don't think any of us get in the positions that we hold in this room without being strong, caring, empathetic people. But I also think we're tired. And being human, that sometimes it takes making sure we're taking care of ourselves, and that we're also taking a moment to even reflect before a visit or an interaction and after, to have empathy for the person before us. And that goes right into the third of thinking what's important to the patients and how the care will be provided, planning before they come into the office or the clinic, and then the follow-up as well. Any comments you guys would like to add on this one? We've kind of covered this one, so if you don't have anything, we'll go forward. Okay. Something comes to you, we can always go back. No, there's no pressure. Oh, there we go. So the quality, this is true, again, no matter what our role, keeping our knowledge and skills up to date, right? Again, it takes motivation, it takes attending things like this, it takes daily action, but making sure that we are staying current, using good communication skills, and I'm gonna hone on what we said before. Good communication skills often means listening more than we talk. Right? And it's hard because we're keeping all those skills and knowledge up to date. We have all this information, right? And we're passionate about it. But again, making sure we listen is the most important communication skill, and also reading those verbals, but the nonverbals as well. And then checking that the contraception or the care that you provided is not out of date. Again, making sure that it's staying current. And that could transfer over to even current birth processes, postpartum follow-up. It could be staying up to date on current policies and state legislation that's changing day to day. That's so important we stay current on as well. There we go. This informed decision making. This is something, when I come to this slide every time, I pause a little bit, because informed decision making is important, but I really believe it's outdated, if I'm honest, that it should be shared decision-making on this slide. So explaining all methods clearly and effective, making sure that the patient hears what you are saying, hearing what is important to them to help them better differentiate between all methods, but then using the tactics to really make sure that, yes, they're informed and they comprehend the data, but it's their decision. Sometimes it goes fast, or maybe that's my fingers. Privacy and confidentiality goes without saying, but this is very important, that trust and rapport. Not discussing patients' information, what they've said, unless they grant permission and unless it's warranted for their safety. And when talking with patients, make sure that we're conscientious of where we're having those discussions, right? Something to keep in mind here, and we'll talk about this a little bit later in special considerations, also making sure that when we talk to patients, those in the room they are safe with. And I think that's a really important assessment, all of us in our roles. There's a few slides that talk about it, but close to my heart, making sure that they're safe, whether it's human trafficking, whether it's domestic violence, whether there's reproductive coercion, right? Them feeling pressured even by a guardian or parent, or even siblings or friends. Sometimes individuals don't feel comfortable making choices if it's different than what their peers are doing. And then making sure that we take all the steps of promptly putting away patient records, whether it be charts, notes, etc. And I believe, and I'm going to call on you guys, this is the same no matter what kind of care you're providing, right? For the doulas and the experts in this area. I know you have to keep records and charts, and sometimes your discussions are even more intimate. So all the more reason to make sure we maintain privacy. We touched upon this too, but participation, not talking at the individual, listening to them more than they're talking, and act on what they say, right? Act on what they tell you is important, and make sure we consider their thoughts. This one I really like, and we could do a lot on just it, but accountability. Hold yourself accountability. Hold yourself accountable for what we bring in, our energy. As you mentioned, I too am a big believer on energy. I teach yoga for fun. That's my side job. But I think it's really important because we are responsible for the energy we bring in the room all the time. And whether it's with collaborative relationships, whether it's in virtual engagements that we finally get to meet each other in person, whether it's with friendships. But how are some ways that, and this may be silly, you might not have really thought about it, but that you hold yourself accountable? I could kind of think about it, right? And sometimes it's just doing that self-check of taking the extra 5 minutes outside when you're late on 2 planes, right? To come in and bring your energy in appropriately. Sometimes I think it's easy if we take it first a little bit more personal, maybe before you respond to a child or a spouse or a loved one, you know, holding yourself accountable. But how so in the women that we care for? Any ideas? Or brainstorming maybe things to take home with us that we could all try. Yeah. I know it's hard.
I think especially in like a medical facility, there's the importance of not only being open to feedback and constructive criticism from your patients and your clients, but also making it very explicit and transparent how they can go about providing that feedback. I've definitely been in situations where it's either like you tell the person who harmed you or you don't get to provide that at all. And so I think just like even making space for that accountability and making that like a really explicit part of the practice, in addition to actually then listening to what they're saying.
That's beautiful. Something that came to me, which I think probably many of us are doing, but hearing your response, it made me think, I remember one of my most treasured mentors was so good, and I try to model this, of being open to encouraging others to also explore other options, right? That you have many options, and this is a partnership. And so please know that I'm open to you exploring ideas, that if you would choose here or me or this interaction or this method, that there are many good resources. But knowing that they get to make that choice and that you are open to, as you said, constructive feedback or growing or doing things better, I think that also is a big one in a way that we can hold accountability. Yes.
My role is more like with admin, so
Okay.
I do a lot of like data and reporting, and sometimes it can be overwhelming, and just a way to hold myself accountable is just to realize that these are people, they have experiences, and just seeing them as humans rather than just numbers. So that's my
beautiful.
way.
Thank you for sharing that. And I think that's huge, right? Like remembering the why. As you said, you know, why are we doing this? It's for the patient. And I could see very much in the busyness of what you do that it would be easy to lose track of that. So, thank you guys for all sharing. It makes this, I think, a lot more relevant and applicable to when we leave. So the CDC does just as what we did, and it's one of the sites when I give you the little references of where you can go. The CDC does a great job of providing core principles of contraceptive counseling or shared decision-making platforms, and they include each and every one of those human principles and ethics that we just talked about. But it's transferable, again, to any type of patient care that you're doing. And I would take it a step further and say it's transferable to any type of human interaction that we have, if we're all really trying to do our best. So these key principles are listed below, right? And this was, again, the shared decision-making model. I would also like to take a minute because many of you, even if you're not the one to write a prescription or provide the contraceptive counseling, you are a resource and a trusted resource of information. There is a tool at the top of the reference sheet I'll give you, and it's from the CDC, and it's called the World Health Medical Eligibility Criteria. It's a big, long acronym, but they update their guidelines all the time. They were just recently updated 2 weeks ago. I used this resource, and there's an app on your phone, and patients can even download it. And although it's a medical resource, it is in a chart format, and it is great for individuals to look at with risk factors or listing all options of the criteria of what's safe and the risk associated with each method. And so I think, in my rooms, I would even pull it up, right? Now, again, I'm older, so when I was in practice before this role, we didn't have it on our phones. I had my little laminated chart, but I pulled it out all the time with individuals and their spouses' supports that were with them. So then they could really see all the benefits, the risk, etc. We talked about how to establish and maintain rapport. These are the things that we talked about in detail. So I'll go through these. I will highlight this one again because you so nicely helped me illustrate it, is confirm the patient's understanding, right? Whatever it may be. And it's going to probably be done in a very different manner based upon the patient before you. And so make sure that you can adapt that to the individual, whether it be their reading comprehension, whether it be their age, their culture, their language, etc. And this is the slide that mentions the teach-back technique in more detail. This is, again, a reference to the World Health Organization decision-making tool. There's another resource if you're looking specifically for contraception tools that has a video link that I included on the sheet that's also very appropriate for all age brackets and also language. These slides, and at the end, I can't share the specific slides, but I can share with you all my references, and I'll also give you my contact information. I'll be around the rest of the meeting and tonight for our fun, so please approach me, and I'd welcome having one-on-one discussions more specific for each of you. So these are, I think, kind of cool. So this goes a little bit further of what we were talking about. And I'm going to walk out here. Sometimes I feel smaller, really silly. Thank you so much. Behind that platform, I feel like I'm not close. So these are just some additional tidbits. We've talked about a lot of these, but for all of us, we can ensure that we're asking open-ended questions, that we're meeting patient statements with acceptance. And I had a beautiful example, and so yours may be different of this, but I met with a clinician earlier this week, and she is amazing in her openness and inclusivity with the patients she sees. So this is the example she reiterated, that when she asks a sexual history, that she teaches her students to respond no different if a patient is hesitant and says 10, or a patient says 1. And that she'll even often, if she feels some resistance, say, that's the number I hear often. Let's talk about how to keep you safe. Let's talk about this, right? So we're diminishing any bias or judgment and ensuring that that patient's like, oh, she stayed very open and accepting to what I shared. I can share other things with her or him. Listen actively to the patient, avoid criticism or blaming them, and checks the understanding of statements, and always ask if there's additional questions, always, and not with your hand on the door walking out, right, in a way that you really have time. For the patient, this really helps, again, common sense, but it helps them to tell us how they're feeling. It helps them to ask questions now and when they come up in the future. They feel comfortable to tell us what's really fearful or causes them fear, is honest about their situation, maybe if there is some coercion or violence going on, or maybe if they're mentally struggling after a baby and they feel shame in doing that, and they ask for instructions and other help. I think that's a great slide. This is very complicated and is more so if you're walking through a counseling process with choosing a birth control method. If any of you, this is relevant or you'd like to speak to it more so, come find me, okay? We talked about this a great deal in your guys' comments, so I'll just summarize it in that informed dissent or informed choice or non-directive counseling, complete patient autonomy, right? We're not giving any advice. And it's listed here as one. I don't think that's necessarily good as either, right? Because maybe the information they got from others is accurate or maybe it's not. But on the other side, we don't want to be the least patient autonomous because we don't want to decide We don't want to advance her Pitocin when she's not given permission. But if we can meet in the middle, right, we can provide the accurate information without bias and let the patient choose. Some of these come up just more in conversation, which I think is beautiful. Are there other questions, comments so far that come to you guys as we're going through this? Anything that I didn't speak to what you've seen so far? I'll take silence as good, but I don't want to assume. You guys did a great job on establishing rapport. We've talked about that. But I think these are good, right? A patient, or a female, or an individual, is going to choose a provider-patient relationship that feels familiar or friendly. And this is to the point we were saying that how important it is for traditional providers like myself or physicians to recognize what doulas, what you all provide, and the services that you provide, because many times you're the individual they reach out to first. And so we need to recognize what you bring to the table and that level of trust and intimacy. And I asked the question, and I'm asking it, I'm throwing it out there to all of you, so you can bombard me. But, you know, in my type role, getting to meet with doulas specifically, and why I really wanted to be here, and we'll come back, is my role is to meet with leaders where there are gaps, right? Where are there gaps in what information, practice, et cetera? And it could be related to the products my organization has. It may not be. It may be that doulas are not receiving support to better educate on postpartum hemorrhage. Or maybe in your doula program, there's a space for medical content on postpartum hemorrhage to educate the female or her loved ones. I'm throwing ideas when I brainstorm on the flights and whatnot. There's a space to educate the patient and or her partner's families of signs and symptoms. But if there's something that comes to you that you think I or organization or medical individuals could do or provide, that's where I really want you to reach out to me, right? And we get creative. Sometimes it happens, sometimes it doesn't. But if we don't know what you need, sometimes it's hard. And so, again, from my background, I recognize what you guys do. And that's why I really wanted to be here. And sometimes it's not in these meetings. Sometimes you think of that later and you have a woman in front of you. Sometimes it's when you're driving the car. Sometimes it's when you're taking time for yourself that you do think of it. These get a little bit more into detail with the shared decision making and getting into specific data and information. But I do want to go into those special considerations because I think that's relevant to what we all do. And again, if any of you have a specific interest into contraceptive counseling, let me know. I could talk your ears off. My dear friend knows that for days. Let's go forward to these special considerations. Here we go. So quality family planning, it doesn't involve just contraceptive counseling, right? And we kind of touched upon this, but we are often in front of individuals that are maybe the only caregiver or healthcare provider they may see. And so we need to have whatever steps, systems work for you. How can we assess for issues of physical violence, sexual violence, unwanted sexual content? We have an expert here on human trafficking, if she doesn't speak for herself, but how do we assess for these things? And so this is one example, right, of an acronym of listening, inquiring, validating, ensuring safety and support. But I wasn't sure if any of you had any tactics, resources, things that work well for you that you'd like to share. And I'll gladly pass this on. Anything?
So my role is in coordinating pregnancy group visits And we have a community Spanish-speaking anti-domestic violence group. A representative from them comes in and shares some information with our patients. And prior to them doing that, the representative and I had a conversation about, okay, so this group can be open to partners. Should this specific group have those partners removed? Is there a certain way we can go about this to make this safe for the patients? And essentially she was like, I'm used to this type of situation, don't worry, I got it covered. But that's just kind of an example of how we made that work.
Do you want this back? Oh, no, I'm just helping. Oh, okay. No,
Okay. I was like, please share. I can use this one. Something that, came to my mind, and you guys hit upon this, is we are energy feelers, right? We know our intuition, and I would encourage us all to follow that as well. And I think of it when I was in practice, some red flags, and not always. If a woman is never able to come into a visit alone, right? Do you have something in the restroom where she gives urine samples that she can leave a note, or that she can contact you or other safety agencies? I think it's really important that you have other safe spots in the visit, because, I remember one particular individual, I could never have time with her alone. And there was a space in our restroom of a number as well as a place to leave notes. And I was able to establish contact with her that way. And that didn't happen right away. I think she had to establish trust in our office and myself before she felt safe to do that. But I think the importance here, you need to have your resources available, because if you have the ability to make contact, you might not get it again. So thank you, guys. Yes. Thank you so much.
Just what you're sharing is bringing up for me when I used to do case management for new prenatal patients that were coming into the clinic. I always, when we were scheduling the visit, I would always say, we'll have 5 to 10 minutes at the beginning of your appointment, just you, so we can take some vitals. And then if you have anybody coming to your visit, you can come back. And sometimes there will be a little bit, partner or a friend or whoever was coming to the visit with the patient, they would try to push themselves. And I'm like, and the clinic was set up in a way that we had a door, right? So we're like, oh, just sit out here. There's not a lot of space in the hallway, and we'll be right with you. Or we would send them to the room so we could still have, and sometimes it was in the restroom where we were having these here's your urine sample. And by the way, can I briefly just ask you these 3 questions to ensure your safety? And is there anything in the visit that you want to keep confidential that you don't want me to ask about during your visit? And so that was just a little glimpse, and sometimes they'd be like, oh, that's fine, or I don't want to talk about X, Y, and Z. Perfect, we'll find another time to discuss that. Thank you for being open. But just setting that ahead of time, so that expectation was set ahead of time, so there wasn't any surprises during the visit. And then reminding them, when they came in as well. So, yeah.
This goes into what we were talking about. There's also, in addition to the violence that we've talked about, there are cases of reproductive coercion. And I think it's easy when we first hear of this if we think of just a partner, right? Putting pressure or expectations on when to conceive or if to conceive, what type of birth control to use. But I think if we think a little broader, and you guys share your thoughts, I think this could even apply to parents, right? It could apply to peer groups. And so I think it's really important that we are highly empathetic and highly aware to empowering individuals to make those choices. And it's not just with contraception, but any of their reproductive care and their maternal care as well. And I'm sure as doulas, I know as a labor and delivery nurse, sometimes you have many opinions of what an individual should do, right? But the number one opinion of who we should honor is the patient before us. There we go. So again, ideas here for screening for coercion are listed, and I love your example of having the quiet space, right, or just one-on-one. And I think for anyone waiting in the waiting area, even if there was areas of resistance or individuals, if they're seeing that that's happening for everyone, then no one's on defense. So it's just the standard of care, and no one's alarms go off that why is this happening? Because we all know that if we trigger something, then the likelihood we'll be able to have contact again, or the ramifications for that individual when they leave may be heightened. This goes into more detail on how to prepare, train, and inform. And again, if you guys have any further questions or need additional resources for this, please let me know. If you are interested in things for human trafficking, as that continues to be a topic, please let me know as well. I have a great expert I can refer you to. There we go, here we go. Getting to the end, but I think this part is really informative. So meeting the needs of special groups. And so yes, this is important, and it's not just for contraception, but let's think of maternal care and talking about the needs of special groups and adolescents. This is where staying current on state policy is so important right now, right? Because even though the state of Iowa and the state of Indiana are both restricted as far as reproductive health care, and it's not just abortion rights, I'm talking about contraception care as well, they are very different. So wherever you are, make sure that you are up to date on the policies and legislation surrounding providing care to adolescents, and then making sure that your materials, as we were discussing, the education materials and or information, the way you convey it is in an appropriate language and also in an appropriate manner and mode of receptivity, right? And so this is where I think, again, social media, we have to have a presence, right, of accurate information and to reach people. Apps, we have to have accurate data. Also, confidentiality comes into effect here a lot in how we're communicating with individuals. Any feedback you guys have or additions you'd like to add on caring for adolescents as a doula or in office situations that you faced? And I have a question as you guys are thinking if there's something you want to add. Morgan, I think you were somewhat sharing that adolescents, when you were at L&D, they had a doula assigned to them. Is that correct?
If they went to the House of Mercy,
Okay.
they were assigned a doula.
Okay. And so I, many times, and I'm going to be honest and share what my first thoughts are. Many times I think of a doula where I live are individuals that are somewhat privileged and able to make that choice. And so I think, again, I'm not sure, of individual sites where adolescents have had access where I live to that. And I think that would be a beautiful resource. So that is already something I wrote down from our discussion to explore. Have you found good uptake in your services by adolescents? I would think so, because there's a lot of needs to be met that I think, unfortunately, could be overlooked by more traditional healthcare providers.
So I think it's also important to state that working with an adolescent and working with an adult is very, very different, and it takes a completely different skill set. Oftentimes, adolescents are really impressionable, and so they can be looking at you as a maternal figure versus I am your doula. And at some point, our services will part, right? Like we'll go our separate ways. So I never suggest that someone just work with an adolescent just because they're a doula unless they have some very specific training and a skill set.
Thank you for sharing that. Hi.
Okay, there it goes. So thinking about contraceptive counseling for adolescents, I'm a nurse midwife, and so I do a lot of care for adolescent populations, especially just gynecologic care, not necessarily even, I probably see more gynecology patients than pregnant patients. With adolescents, I feel like a lot of them come in and they like know what they want. And I think that's a common misconception is like they're undereducated, they don't know what they want. And like you mentioned earlier, there's assumptions about what things they should be using. So I think that's an important thing to remember, like just because they're young doesn't mean they haven't like put in the time to figure out what options are best for their life. The other thing I would say too is as a provider and thinking about access and ensuring that adolescents in particular have access to the full scope of contraceptive options is we need to pay a lot of attention to like pain management and things like that for like IUD placement or like, you know, the next one on placements and things like that. That's a very like popular topic right now on social media. And if we're not thinking about including that as part of our counseling, that might, you know, inhibit people's access or desire to be able to use those methods that might actually be the best one for them.
You're so timely, and because you brought it up, I'll go there. The World Health Organization, their medical eligibility criteria that I was mentioning, the most recent update 2 weeks ago, really highlights and addresses pain management with IUD insertion. And I will be very candid, I love all LARCs, right? Before I took my current job, I had an IUD, I believe strongly in them. But I think pain management is something that's been overlooked for a long time, not only in IUDs, but also in implants. And I can speak for the implant that it's part of the package insert that the arm be numbed, right, prior to insertion. I have had providers, luckily it's been very rare, that don't do that, I've been reported. That's not on package insert. IUDs, until this recent update, it will be interesting to see how we as clinicians adapt to that because it varied a great deal on pain management for IUD insertion. A positive of that, and I would highlight what you say and mimic it, is I love that adolescents are more empowered now with knowledge. And it goes back to that point that I said, even if it's not accurate, it helps dialogue. And they're being active in their choice, and they're taking responsibility, and we are able to set a pattern of how they manage and respect their own bodies and expect that going forward in healthcare. And I think that's huge. I agree with you that people assume they don't know what they want. Providers more and more that I'm meeting with tell me, oh, no, they know exactly what they want. And I said, that's great, right? Do you talk through the reasons why, not to change their mind, but to still educate them because maybe they think they know what they want, but then maybe 3, 4, 5 months later, it's not working out so well and they want something different. And I think, you know, the other thing I've been trying to reiterate and getting to know you and even hearing you talk, I can almost bet you already do this, is we need to counsel all women, but adolescents especially, they don't have to stick to whatever they choose initially. If you don't like this, you don't have to stay, right? You have agency to come back and use your voice for us to find something different or to change your mind. So thank you for sharing that. Yes.
Hi. So I used to work at a local agency that is focused on women under 24. So this is very, I don't know, kind of fresh in my mind from the last couple of years. But something that came to mind for me when talking about birth control options for adolescents is that a lot of them are very hesitant to use birth control because of any potential mental health side effects, and not being worried about locked into something like a LARC and not being able to get it taken back out if they do have those intense mood swings that they're already going so up and down in their lives. And I know I personally, when I went to college, I got on birth control for the first time. I had no idea that it was an option to change to a different one and not be depressed all the time for a couple of years. And then I switched methods when I moved, and I was like, oh, I didn't have to deal with all that. So I think that's a common thing that people are talking about on social media, as well as, you know, what is and isn't normal for those mental health potential side effects that can come up and really affect the teenage mind.
I agree with you. Thank you for sharing that. So these are some other populations that we would need to be mindful of. Coexisting medical conditions, maybe those individuals, this is for contraception, taking seizure medications. But I think you bring up a beautiful point, and it's mentioned here with mental health disorders. But I think for myself, and you may do the same, anytime I start an individual on contraception and they have a history of depression, whether before pregnancy, after pregnancy, or any anxiety or mental health struggle, I follow them a little bit more closely. I'm a huge mental health advocate. I think it's really important that they have that visit and follow-up already established before they leave, and that they also, again, know and trust that they can call and make changes at any point. There's also the mentioning here of individuals with substance use disorders is something to keep in mind when we're making care plans as well. You guys are so good. You kind of brought this up already in our discussion, so well done. But talking about individuals with disabilities and making the assumption that they're not sexually active, I think that's very important, that we all are mindful of that. And then here with barriers, these are barriers for contraception access, but I think they apply to barriers for any type of maternal health care and or reproductive health care. There's knowledge barriers, which we've talked about a great deal, as well as cultural, religious preferences. Gender-based barriers, which I think we all need to make sure that we're staying up to date again on legislation surrounding this, but also being open and unbiased in treating those transgenders are considering undergoing such services, and making sure that their reproductive health care and contraceptive needs are met as well. We talked about cost and insurance cost related barriers, not only to doula services, but it applies also to contraception care, and then environmental level barriers. Is there anything that you guys think is not listed here? I think this is pretty conclusive to what we said, and we talked about a lot of these organically. This lists a lot of things that we've also talked about, being free or subsidized services, prioritizing early sexual education. There is a list, and I have been educating myself on many of these, so I am going to refer to my notes because I thought this was really cool, and you guys may already be ahead of me. But I've been doing more research, and there is tons of reproductive health education, both for maternal health, meaning common things like postpartum hemorrhage, hypertension in pregnancy, mental health struggles during and after, through the AIMS bundles through the CDC, which is abundance, right? There's so much for both providers and patients as well as their loved ones. Another great source that I have really enjoyed and learned a lot from is the Reproductive Health National Training Center. They offer education to Title X clinics across the country, and they are amazing as well, with free resources both for providers, for processes, even in ordering, billing, data management, and in patient counseling. And then the last one that was the most new to me, and I did list it as well, is a national organization called Direct Relief. And it is the largest charitable organization of free medications. And so when you go on their site, and I'll give you guys the list, they collect medications from donations all across the country, and you can list what type of conditions, right? For example, so for myself, I'll share this. I was interested to know if our organization, because we partnered with them, was making implants available or JADA systems for hospitals, and also a new vaginal health product. And you could see the number of units that were being donated and where they were going, and you can apply if you're a provider or a clinic to receive these services. And again, they have an emphasis on maternal health and reducing maternal morbidity and outcomes for families. So that is a great new resource to myself that I just recently found out in the past 6 months. And that's what I have. You know, I thank you guys so much for being vulnerable. I know sometimes it's uncomfortable to share. I know, sorry. I'd rather talk to you. I think it's uncomfortable sometimes to share in a large audience or even in a room and know that others are watching and we don't know their response. But we're partners, right? And I think each and every one of us, what we do each and every day matters. And it's important that we keep our cups full, especially now and in the next few months to come. But I will provide, this is my direct email for work. I'll be here today, tonight. Come up to me. You know, I'll probably come up to you guys. I've already asked lots of questions just to help me learn personally and professionally how I can better support you all. But thank you so much for what you're doing.
Thank you so much for that great presentation, Bree. And we also was receiving comments online for your contact information, and I let them know it would be shared at the end, so I'm glad you shared it. So we're gonna take a quick 10-minute break so you guys can grab lunch, and then we'll be right back with our next presentation. Thanks, y'all. All right, everybody. You can wrap up getting some lunch, and you can eat at your spot, but we're going to go ahead for the sake of time and get started again. So I'll give everyone a few seconds to get back to your seat. All right. And I will be introducing our next speaker in just a second. You ready? Okay. All right. So our next speaker is James Hogue, a Detroit native who has over 15 years of experience in education and youth development. Growing up in a large family and being an uncle to over 20 nieces and nephews, he naturally gravitated towards birth education. James is a trained birth doula through the National Black Doulas Association. His passion for birth education became personal during his wife's complicated pregnancy, which included challenges like this. I stumbled over this word a little bit. Oligohydramnios and preeclampsia. This experience underscored the importance of prenatal education, preparation, and advocacy. To address these needs, James founded the nonprofit Fathers Assisting Mothers, aiming to educate and empower expectant fathers, helping them support the mothers in their lives during this crucial period. Let's welcome James.
Well, good. Is it afternoon? Is it afternoon already? Yeah. Well, good afternoon, ladies and gentlemen. Thank you for just this opportunity and the experience to be involved in this time with you all. My name is James Hogue. I serve as CEO and co-founder of Fathers Assisting Mothers. We are a nonprofit 501c3 organization that's designed specifically to bring birth education to expectant fathers. Our heart and our goal behind it all is to make sure that fathers, support people, brothers, uncles, grandfathers, whatever, understand that their role is vital, and then here's how you can play a role in advocating for the mothers in your lives. And so for just a little bit of time, I want to walk down that path, walk down that story, how we came about. We'll unpack a little bit of our impact, what we do, how we do it, and really look at the next steps that we have laid out for our organization, and what are some tidbits that other organizations like yourselves that you all have and roles that you all play, and how do we can reshape the lens a bit to make sure that fathers are being included throughout this process. Because there is, a part of the equation is fathers, and if we are excluding and not really bringing them into the process, then we are missing out on a vital component that can change some of these disparities that are happening within birth here in the U.S. So let's get right into it. I probably clicked the slide earlier. That's my bad. So welcome to Fathers Assisting Mothers, empowering expectant fathers, supporting strong families. So let's dive into why we began. We came into existence a little over 4 years ago. So my wife and I, that's my wife right there, Shanquita, ain't nothing sweeter, that's what I call her. And so that's my wife there, and when we were expecting, we had a plan. We had a plan for a completely natural home birth, and we were on track for it, right? We were on top of our visits. We worked out. We both were college athletes, so we worked out the entire time throughout our pregnancy. We made sure we stayed on top of things. My wife didn't like to drink water before, but she was drinking hundreds of ounces of water a day, so we were on top of everything. We felt like, okay, this is the path. However, about 7 weeks prior to our anticipated due date, we began to experience some complications. Those complications presented themselves as preeclampsia, oligohydramnios, extremely low amniotic fluid. And then our midwife had to break the news to us and this home birth that y'all want is probably not going to happen. Right? And she was like, yo, y'all probably should head over to the hospital to get checked out because what I'm seeing, the swelling, it was a real bad problem. And so we were going to try to get a second opinion to fight through, but as we were driving to the hospital, true story, as we were driving to the hospital that day, about a mile from the hospital, we had to pull over. My wife would not stop throwing up. She began to profusely throw up for about 5 minutes right there on the side of the road. So once we finally got there to the hospital, they did the test, they ran through and said, listen, we need to go ahead and make this induction happen. And so we ended up having our son about 6.5 weeks early. He spent about 3 weeks into the NICU. But thankfully now we have our healthy 4-year-old son named James, who's, that's the reason I'm late this morning, y'all. We drove up, my guy Matt and I, we drove up from Kansas City this morning, and he didn't want to do what he was supposed to do this morning. So anybody got a 4-year-old out? Any 4-year-old parents? Okay, all right, well, we here with it. So here's the situation. So we founded the nonprofit, and so what we began to experience as we had to make that transition, I saw firsthand how valuable it was for me to be informed as a partner. There were times where I had to have literal back and forths with the medical staff to make sure that we were getting the care that my wife was getting the care that she deserves. My wife is a nurse. She's been a nurse for over 10 years, and she was like, yo, even in this moment, I know what's happening, but Jay, I need you to handle it because I'm trying to focus on these contractions. That's what I'm focused on. So literal back and forths. And so after we gave birth, I had about 6 of my friends who were getting ready to have children. I wanted to make sure that none of my friends within my sphere of influence walked through this situation uninformed. And so we began to have phone calls, and they began to ask questions that I didn't have the answers to. So I reached back out to our doula, who was a trainer with the National Black Doulas Association. I went through and got my training there. And I tell people, there's a 0% zero chance of me showing at your birth. I don't want to show up at anyone's birth. Instead, I use that training to pour into fathers to make sure that they have what they need to walk through the process. And so we started our classes in January of 2021. We officially launched with our nonprofit status in November of 2022, and we've been on a mission since then. Whenever I tell this story, whenever we walk through this, the biggest thing that I want people to understand is this. When we experience an adverse situation in life, we have a couple choices to make. We can either choose to be upset about that situation, or we can figure out how we're going to use that to move forward and to help someone else. I'm sure y'all heard the old adage, like, when life gives you lemons, you do what? Make lemonade, right? When life gives you lemons, but I don't believe that. Here's the deal. But really think about it. If all you had was lemons, then all you have is bitterness. If all you're taking is just the lemons that life gives you, you're stuck with the bitterness, that adverse situation, that trauma that's there. But what do we need to make lemonade? We need lemons, we need water, and then we need what? Sugar. Sugar or some kind of sweetener. You may not be on refined sugar, I get it. Whatever kind of sweetener that you're choosing to use, let's do that. But in order to make something great out of life's mishaps, there has to be some water and sugar that you add to it. In this situation, the water and sugar for me was knowing that I could use this situation to impact someone else's life. The sweetener in this situation was that my wife and my son, we made it through, and now we're able to use that experience to help other people do the same thing. So as we are unpacking and walking through the rest of the things today, I want us to be mindful and understand that, the mishaps that life gives us are real mishaps. But with the proper vision of it, we're able to take life's mishaps and make magic out of it. So as we are thinking about our stories, thinking about our experiences that we've had, think about what will be your water and sugar in those moments to help someone else move beyond and continue to grow and do the same thing. And I feel like that's what we did with FAM, or Fathers Assisting Mothers. We're able to take the mishap of having a dream that we desire not come to fruition, and now create an entire program that we're able to impact and help change the trajectory for so many people moving forward. So let's dive into our focus community. So our focus, as I said, we're specifically designed for expectant fathers. We're serving expectant fathers nationwide. We're based in Kansas City. but when we started in the middle of the pandemic, we had people all over the country. So our first cohort of 6 people included one guy from Kansas City, one guy from Houston, 2 guys from South Carolina, one guy in Atlanta, and a gentleman in Cleveland, Ohio. That was our first cohort, and we continue to build out from there. And so our focus is on Black and brown fathers, but more specifically, partners of Black women. And this is the case, one, because I'm married to a Black woman, and that was the experience that we walked through, but then the numbers, I'm sure we all are aware of the numbers here. The numbers indicate that that's where focus needs to be in many cases. And so our care is tailored specifically for fathers. And so what does that mean? We are walking through the entire birthing process with our fathers to make sure that they understand and see, here's how your role plays out in this particular space. Okay, you all in first trimester, things are trying to get figured out. Okay, let me help you walk through what you should be doing during this time to advocate and walk through the process with your partner so that she doesn't feel as if she's going through this alone. Our sole focus is to be there for the expectant fathers so that they can see, here's my role, here's how I can show up, and here's how I can alleviate some of these issues before they become larger ones moving forward. How we show up. And so we show up in a variety of ways. One of the ways that we show up as an organization, we hold one-day events that are specific topical-based events. So our most recent one-day event was around the NFL draft back in April. And the topic of that one-day event was, how do you draft your winning birth team? As a father, what is your role on drafting your winning birth team? So we had guys come through, they wore their NFL team gear, and then we began to talk through, okay, based upon the game plan that you and your partner want to have, okay, you want to have a completely natural home birth bet. I like it. Now, what people do you need to draft on your team in order to make that happen? All right, well, bet if that's the case you want to go, you probably need a midwife if you're doing it at home. Or you probably need a doula as well. You might need a nutritionist or whatever the case may be. So helping guys see, based upon the goal that you and your partner have, here's what you can do to help with that. And here's how you play a role in making that happen. So we provide one-day events for fathers and for community members as they walk through a specific part of their process. Next, we offer one-on-one coaching. We have individuals who are like, man, I love what you're doing, but I need more than just a one-day workshop. I need more than a one-day workshop, but I also want my privacy. I want everybody in my business. I got you. That's cool. So we walk a one-on-one way. We walk with partners through the entire process. We just signed up one couple on a one-on-one process with the father in Norcross, Georgia. This is their first child. They've been married about 6.5 years. And so the dude is like, bro, I want to learn more, but I want to ask a lot of questions. So I think I need to have a one-on-one session. I'm like, I bet, but we capping these to 45 minutes, 50 minutes per session. Like, I'm not going to be on the phone with you all night or on Zoom with you all night, bro. But I got you. If you need it, holla at me. And so we do the one-on-one coaching, and our flagship program is our Dad Doula Bootcamp. This is an 8-week program where fathers walk through in a cohort model almost everything that they need to know about the pregnancy, delivery, and postpartum process. So we start everything from conception through early postpartum on what is your role throughout the process. One of the major things that we lean into in our Dad Doula Bootcamp is understanding how to be an advocate. What does it look like for you to go into these spaces if you are at home, birth center, hospital, and advocate for your partner in an effective way? And one way we do that is really diving deep into some of the terminology that happens within a hospital setting. Helping guys see that, when you hear these things, here's what's happening, and here's what you could potentially do to help within that process. And so our Dad Doula Bootcamp is a cohort model, and we enjoy that because it gets guys of 5, 6, 7 groups of guys, 7 gentlemen together, and they're all in a similar phase of life right now in that space. And so they now have another guy that they can reach out to, like, I'm feeling this way. Or, my girl just did X, Y, Z. Am I tripping? Am I thinking about this the right way? Yeah, bro, you tripping, right? We can get to have some of those conversations if that is the case. And so the goal is to make sure guys don't feel as if they're walking through this alone. Walking through this by themselves. And our Dad Doula Bootcamp is beautiful because we often bring in experts to speak into it. So I have the training, I have the information that I've been walking through, but our co-founder in our organization has been doing birth work for the last 15 years, so she comes on, leads some sessions. We have a few midwives that come on and lead sessions. We have nutritionists that come on and lead sessions. And so we have a communal feeling around what we do so that fathers understand that this fully is happening for us so that we are able to walk through it appropriately. So those are the 3 ways that we show up. One-day events, our one-on-one coaching, and our dad doula boot camp. Any questions or thoughts on any of those 3 things or anything that we've ran through thus far? Yes, ma'am. Yeah. Yeah. Got you. Very good question. Very good question. So yeah, one, you are completely right. We are not a certifying body for guys to become birth workers in that at all. That's not the plan. That's not what we're doing. But we are treating them to support in a doula-like fashion, right? So what we're walking through in our Dad Doula Bootcamp is that, you may have the most amazing doula. We had an amazing doula for my wife and I when we were going through the process. We had an amazing doula. However, our sessions were only certain times, and we had to call if we needed extra help, right? But it was great for me because I was able to recognize, hey, something is off. I've been noticing that this pressure has been going up every time we take it over the last 2 weeks. I'm able to track things a little bit better. I'm noticing that these things are there. And so the goal with what we provide in our Dad Doula Bootcamp is for them to be able to recognize and see the signs and symptoms that are happening. They can almost act as a first responder, see like, this is happening, let me get the help that's needed. Or, our doula may not be able to show up when we need them to, but I want to make sure that you have what you need to walk through the process. And so the goal is for the fathers to be as informed as possible to make sure that they, one, are able to be there and advocate for their partner as they need to, but then also for them not to feel as if they're isolated from the process. If I'm understanding and learning all that's happening, I'm more connected to what's going on. But I definitely get what you're saying, though, in that aspect. All right, perfect. So yeah.
You use the word, thank you. You use the word father a lot, which I think is great, but are you using any other inclusive language to include like the LGBTQ community that may not have those binary terms when it comes to parenting? So like, how do you include like that type of family that isn't the typical binary man and woman family, but that still might be interested in programs like this? Yeah, got you. Great question.
First part of the answer is that we are specific. We have a very narrow lane. We know our lane, and that's the avenue that we choose to go down. Based upon that's the experience that I had. I've had 2 guys that come through, or 2 individuals that come through the program who were non-binary that didn't ascribe to that, and we're able to tailor the information so they can feel as if they're included into it, but knowing on the front end, hey, this is our focus. We're not excluding anyone, but this is the lane that which we started to go down. And so that's the hard part, not necessarily hard part, but that is one of the decisions that I was okay with making when stepping into the lane, knowing that, hey, I may be in a space that is not as wide open for a lot of people. It may not catch on as quickly, but I know the demographic in which I'm leaning to is one that I have a heart and passion to lean into. And so that's, very, very good question. Very good question. All right, so that is how we show up. So how are we sustaining our mission, right? So as a newer nonprofit, how are we sustaining our mission? And so we are less than 5 years old. And so as for those who are in nonprofit space or in the funding space, you know that being less than 5 years old is difficult to get funding in many cases, grant-wise, and being a Black-led nonprofit, being a nonprofit that isn't outwardly facing as inclusive as others may be, it becomes difficult to get the funding. And it is what it is. I ain't tripping on it. I know that. I understood that going in. And so we're shifting our model, right? Shifting our model from going out, just doing grants. We are now getting contracts with organizations to provide our services for them. So those 3 organizations there, National Black Doulas Association, the Hope Center in Kansas City, Start at Zero in Kansas City. We just recently signed an MOU with Uzazi Village in Kansas City that we're offering services for those individuals. And so that is our shift to service-based funding, but then also we know that we got a product. We know we have a product that we can market. And so I know y'all seen the camera guy with me. We're filming our self-paced program. So we have a self-paced program where we're turning our 8-week cohort model-based program into a module program, which will help us be able to scale and to provide more impact in a much more efficient way. And so the partnership that we have with the National Black Doulas Association, we're coming on as the official coordinators for their fatherhood programming for the NBDA. And so that will provide us with more opportunities to provide the services for other organizations, training them on including fathers, but also having the fathers of their partners have a service that is already attached to what they're doing. And so our goal is sustaining this mission, but pushing it forward to a point where we're able to do it without having to rely also heavily on grant dollars in that way. But knowing that a nonprofit is our tax status, but we're still a business, grinding in that way to make it happen. And so that's how we're shifting to sustaining our mission. And here we go. How do we expand our impact? So expanding our impact, when we first came in, there was someone who spoke about the use of social media. I think when I was walking in, I heard someone talking through that, the use of social media. That is one of our most impactful ways. When we were getting started back, a few years back, I met someone who works for a prominent foundation in Kansas City, the Hall Family Foundation. And he was like, yo, James, one of the things that I want to encourage you with, and this is a great tidbit for many of you all as well, they're like, yo, one of the ways that we find organizations to partner and come alongside with is how impactful are they on social media? Like, yo, we know that's where things are moving towards. And he was like, yo, I began to find individuals to fund and individuals to come alongside about how consistently are they showing up on social media and what those presence looks like, and are they providing quality information there? And so that is where we begin to lean into. And so right now, we're thankful enough to have over 15,000 interactions monthly on our social media platforms. And the main way that we do that, we have a series, our street interview series. And so what that looks like, we go to prominent areas in our city, set up the camera, I have a sign, a microphone, and I stop guys on the street and ask them questions about pregnancy, labor, birth, delivery, and postpartum and see what they know. It's pretty funny, some of the responses that we get, right? We just recently came back from Birmingham, Alabama at the Alabama Greek Picnic, and we were down there just polling the fraternities and sororities about what they knew, and some of the answers were pretty comical. If you guys want to see them, we have them. I have a link for our social media on there as well, where we'll show some of those, man. One of the guys, we like, yo, guy, what's a VBAC, bro? What's a VBAC? VBAC. He said, man, I played VBAC in college. Nah, that's not it, bro. That's not it. That's not exactly what I meant. Asking guys, yo, how many trimesters in pregnancy? One guy said 12. I said, bro, if your partner was pregnant for 12 trimesters, then she'd be mad about it, bro. And again, these are funny moments, but these are moments that are engaging, spark curiosity. Dudes leave from the table like, yo, bro, I'd never heard of that. I'm so glad I did. Thank you for stopping me, right? These are moments where, again, these guys are juniors, some just recently graduated college, not having any children yet, but like, yo, bro, if you go down this route to have children, make sure you get yourselves a doula. Like asking them what doulas are, they have no idea, no clue. And so now it's become more palatable and more relatable for them to understand what's happening. This is such a very, very vital part of things because, so brief background. My undergrad is in education, elementary ed. My master's in education as well. So I taught elementary and middle school for the last 8 years, was an assistant principal for 2 years, and just recently resigned from my position as assistant principal last August to put sole focus on the nonprofit, right? So this is truly, truly a passion in the heart where I am. Within education, if I've always taught in inner city schools. So I taught in inner city Greenville, inner city Atlanta, inner city Kansas City. And the issue is that when most black boys go through high school, they don't see many teachers that look like them walking through the process, right? And the reality, it becomes to subconsciously begin to think like, yo, if I don't see anyone that looks like me, that can relate to me, that's valuing this education, then subconsciously begins to think like, yo, this ain't for me. Like, this education thing must not be for me. Likewise, like if guys are walking through this process with their partner being pregnant and no one is speaking directly to them in a manner that they can relate to, that kind of looks like them, that they can connect with, they begin to think, oh, I know I played a role in making this baby, but there's nothing else for me to do in this process. So what's happening? So how do we help those individuals see that there's someone, that they have a role, that their role is vital, and the role really is a game changer throughout the process? And our strategies help us build the community that's necessary for them. We are really looking at how do we build, tear down those barriers so that fathers truly see that there is a space for them, and then their space and their role is a vital role throughout the process. So how do we engage in expectant fathers? So some tidbits on for you all as you all have organizations that may be looking to engage fathers. Be intentional including fathers in the process. The intentionality behind it is key, or intentionality behind including the partners is key. Again, we're taking into consideration the other factors that may be present, and it may not be the safest thing to include some of these people in the process. Understand that, but for those who are, be intentional about including them. That may look like if you're doing a visit with someone and you're trying to demonstrate a counter pressure or something that they can provide it, have them do that, right? Show them how, have them do that, or walk them through, hey, here's tangibly one thing that we do with the fathers on the very front end when we begin to work with them. I'm like, all right, bro, 2 things I need you to do off rip. Get on Amazon, order a birthing ball, and get a blood pressure cuff, right? Order those 2 things, right? Help them walk through how to do those, how to properly use them. And then like, yo, every day or however, what interval you all choose, as you take those blood pressures, bro, pull out the notes app in your phone and just start writing them down. You begin to see how to track trends of what's happening. So when you go to the visits, you now have, hey, yo, man, yo, doc, like the last several weeks, man, we've been checking pressure, and like every day it's been going up by like 2 or 3. Like we've been noticing that it's been creeping up or creeping down. That gives them an easy win. Like, okay, I can do that. But when we go to the visit, I have that to bring up. Now I am motivated and I'm rewarded for like, yo, bro, you did that. Again, we're not trying to just reward and just codify people just because, but this gives guys a tangible way of knowing, like, yo, when I do this, here's the result. Like, yo, we real simple. If we can see that we can do something to make a result, we don't need a lot. Like, we don't need a lot. Like, and so be intentional about including them. Develop focused outreach for the fathers. That may include connecting with individuals who are experts in that area to make sure that guys can get there. But fathers want to, and guys want to show up. When I was a school leader, whenever we sent something home and we said, yo, families are welcome, mom would show up. But when we said, yo, dads, we need you in the building, they'll show up. Like our largest event that we ever did was our dad and daughter dance, or our dad's Donuts with Dads event. Those were the largest ones that would fill out the cafeteria every single time, because we were specific on saying, yo, bro, I need you in the building. I need you in the building. I'm looking you in the eye in the car line. I know you coming. Pull up, right? When we're specific about what we need for the guys to do, generally we rise to the occasion if the environment has been laid and the work has been laid for it to feel safe. Education and support to highlight the father's crucial role. Don't allow them to feel as if their role and their presence isn't necessary or isn't needed. It is. Like, again, I know moms and are 100% capable of making things happen, but understanding the vital and crucial role that dads play throughout the process is truly, truly a game changer. That's all we have for the most part. Overall, our goal and our heart and our desire behind it all is to make sure that we provide the space for expectant fathers to feel included and understand that they have a role to play throughout the process. This is birthed out of an experience that was adverse, that we didn't want to have, but we feel good about the magic that we're starting to make out of the mishap that happened, and how we're creating a space where fathers can come along and understand that they have a role, this is their role, and here's how you can show up. Any questions? We have time, open up for questions, right? So questions, concerns, nonviolent disagreements, whatever you got. I ain't trying to fight nobody. Yeah, would love to field any questions, any critiques, whatever. Like I'm super open to hearing it so that we can continue to build.
So I want to say one thing. I think that when you are working with a vulnerable population, it's important to show up authentic. And I don't know if everyone is able to recognize even the language that you're using, right? Like, yo, pull up. Yeah. That's going to mean something very different in our community versus other communities. For sure. Yeah. And so I applaud you for showing up authentically and being able to be like, hey, I'm trying to not speak for people, but help them find their voice and shift the narrative of Black dads do show up. Oh, 100%. Because it's out there as if they don't, so.
Got you, yeah. I can turn it off and on, but I choose not to, like, right. So, yeah. No, I'm with you, yeah. Yes.
Thank you. So I've noticed that you use a lot of inclusive language when it comes to the pregnancy. Like you say, like, we were pregnant, or we gave birth, that kind of language. In your curriculum, do you talk about like the mother's like unique role at all, just like how to support her with, because I know like if you haven't done it, like it's hard to understand it. So like, do you speak to that at all?
Yeah, absolutely. So we make sure I'm understanding. Do we speak to in our curriculum just the unique role that mom plays throughout the process, right? Yeah, what's happening within her, how she. Oh, yeah. So what we do within it, one of the earlier sessions that we do within our 8-week program is understanding like what is happening within your partner's body and mind and partner's mind and body throughout the process, right? And so during that time, my wife is a mental health nurse, and so we bring her in, and she leads within that aspect of talking through, man, how did our dynamic shift, and how did her thinking begin to shift throughout the process? And so we have that laid into it, and then there are often times where we will have follow-up. So every week we do something, we have follow-up, okay, go back and talk about this with your partner, and then the beginning of next week, we kind of recap what the conversation was like with their partner to kind of tailor what the next steps look like as we move forward. So yeah, we spend a good bit of time of making sure that we understand, yes, it's impacting you, but here's how it's impacting your partner who's doing the majority of the heavy lifting during this time. That answer? Okay, for sure.
You can go to her.
Hello. Thank you so much for sharing this amazing program today. It's been great. I just was curious. You mentioned that you are making sure that these dads are really prioritizing doing things like regular blood pressure checks, which I love. I come from a public health background. I was just curious if the programming that you offer is also including kind of that wide array of other maternal health warning signs that dads can really help look out for, both during the pregnancy and also in the postpartum, because so many, especially Black families, have things like postpartum preeclampsia that aren't as well known about, crop up in their birth outcomes.
Yeah. So we spend some time on it. We are building out more parts of the program, but a lot of it does deal with how do we recognize signs and symptoms throughout the process, right? And so one of the main ones that we look at through also is that, my wife began to complain about pain in her upper right quadrant about like 30 weeks, right? 30 weeks in, I didn't know of that initially, so we began to walk guys through, okay, if these certain things are coming up, here's how to recognize. Or, man, early on as possible, man, talk with your partner throughout the process of how she's feeling in many different ways. almost every week, check mark, so that if things begin to shift, you begin to see those. And a part of our program we walk through, we have a part of it where, if a question comes up or your partner is exhibiting something that you don't quite understand, you have myself, our co-founder, Brandy, who's been a doula for the last 15 years on call, and the midwife who works with us. Hey, my wife is saying X, Y, and Z. I'm not sure what's happening. If I don't have the answer, we connect you with the person to get the things done. So, yeah, we definitely tell them and walk them through how to not do like a body scan, but to how to walk through, ask the right questions, and see how she's walking and moving and see what's happening to make sure it needs to be brought about. Great question.
I have a question. You talked mostly about how you're training the partners to support the birthing person. What kinds of things do you do around like newborn care and parenting and things like that?
That has been, we haven't really done a ton, right? I'm a person, I love to stay in my lane, right? I love to stay in my lane, and we are desiring to expand that a little bit more, but I'm keeping it as I'm about to keep it a buck with you. I'm in the middle of trying to learn that myself right now, right? And so I don't want to be like, yo, this is what you do. But I've just been blessed and grateful for the network that I've been able to build and connect with over the time. And so there are a few guys that are in the network who have that experience, and we're able to connect guys with them. But we haven't developed a program or curriculum specifically for early fatherhood just yet. And the reason being is that I believe that there's a lot of programs out there for fatherhood already, but there's not many in the space that we're in with the perinatal side of it. So we want to just lean into that a little bit more before we build out that aspect. But if fathers have those questions, we're able to connect them with some of those resources in that way. So yeah, not yet, but because I'm trying to figure it out. If you know the plug, let me know so I can sign up for their class. He didn't want to get dressed this morning. I'm like, bro. So funny. So my wife is she's a mental health nurse. She works third shift, right? So she does overnight on Tuesday, Wednesday, Thursdays. So Mondays, perfect. Fridays, Saturdays, Sundays, perfect. As soon as she go to work, my boy forget all the whole routine. I'm like, bro, it's time for bed, and it's time to. He laid in the middle of the floor trying to break dance like Ray Gun all last night. I'm like, bro, get up, man, get up. So yeah. If you got it, let me know. For real, if you got it, let me know. But overall, that's how we impact. I know I heard someone mention earlier about teen. Oh, my fault. Yes, I'm gonna stop talking. Yes, ma'am.
Oh, thank you. First of all, just commend the work that you're doing. I talk birth to my husband all the time, and he thinks he's a man doula now. But I love the term that you have coined with regard to training dads. And I think that there's a lot of unique roles that fathers can play, and I certainly encourage that as a doula. Even things like skin to skin immediately after birth is such a beautiful and bonding experience for dads to be involved after baby is born. But just curious about the decision-making process during labor and delivery. Oftentimes, like with the skin-to-skin, for an example, mom may be going through some things immediately postpartum that dad is really crucial in being able to step in and make and kind of fill that gap, if you will. So just curious as it relates to the decision-making during labor, some of those difficult decisions, kind of how you instruct men or fathers to aid in the decision-making process as it relates to decisions that have to be made during labor?
Yeah, great question. So part of the 3 ways that we show up are personalized, Dad Doula Bootcamp, all those things. If anyone comes in to get services from us, we provide them, help them walk through a well-thought-out birth plan, which includes some of those decision-making processes throughout that. That's one aspect. We make sure they have that. We walk them through how to create that. But then the biggest thing that we lean into is just the education. Like, bro, I don't want to make any decision for you at all. But what we want to do is provide you with the information so that you and your partner can get together and make the informed decision. One of the easier ones, like, so for example, on Tuesday, I just did a talk at a barbershop in Kansas City with the health department, and we were talking through with the guys there at the shop on decision making, right? And so I typically lean into the BRAIN acronym, like the benefits, risk, alternatives, intuition, what if we did nothing, right? So help them understand that, yo, when you have a question or something brought up, bro, you can walk through this BRAIN acronym with yourself, talk it out with the provider to make sure that they've thought about it. And if they get upset about you asking these questions, that probably ain't the provider for you, right? And so we are intentional about, one, providing with the information so that they can make an informed decision, but then also providing information about the various scenarios that could happen, right? So based upon our experience, again, we were on track for a completely natural home birth, but our doula was made sure to inform us about all the different other variations that could happen. And that changed the game for us, because when we were at the hospital, again, I know what I look like. Young black dude with locks. I had my hoodie on. I'm chilling. We making it happen. And so when the doctor was like, yo, we about to induce, and I was like, well, you asking and telling, right? That's the first thing. But then also after we got through that, and I was like, well, let me understand this. What method of induction are you using? He was like, well, I'm like stuttering because he didn't expect us to ask that question, right? So understanding once we have, and my wife named Shanquita as well. So you looking like, bro, y'all don't know nothing, right? It was funny to me. And so that idea was like, yo, once we give you the information, you're able now to stand firm in what you know, right? And so we walked them through terminology. We walked them through understanding what may potentially happen in certain phases of birth. Like, so you understand what's going on so that you're able to see, yo, are you doing that right or not? Or I can ask the question because now I understand what you mean. When you say, oh, we're -3 centimeters dilated at like 40% effaced. Okay, I know what that means. Now I'm able to activate and do what I need to do to help baby come down and do whatever needs to happen. So that's how we help with that decision-making process, making sure they're well-informed so that they're making the decision that fits with the particular situation that they're in. Well, thank you all again for your time. I know some of the stuff got cut off. Oh, there it is back up. But yeah, feel free to reach out. Would love to connect, share any resources that we have. We are, I'd say, in the process of finishing up our self-paced course. We have a webinar that we finished shooting and we're editing right now. It's a 30-minute webinar for fathers. So it's a quick 30-minute webinar that guys are able to see the phases and stages of pregnancy, what their roles could potentially be at a very easy route. And so we are really on a mission. We're really on a mission of reducing these disparities one expectant father at a time. So I appreciate y'all time. And yeah, let's connect. Thank you.
I'll take this.
Thank you so much for that wonderful presentation. I'll be introducing our last speaker today. Jessica Houseman Whitehawk Wakanji Winga, meaning Good Thunder Woman, is a member of the Winnebago tribe of Nebraska and the Santee Sioux descent. She is a mother of 3 children and 1 baby grandson. Her experiences as an Indigenous woman navigating oppressive and racist systems throughout her life gave her a drive and purpose to do the birth and restorative justice work she does today. Starting with a GED, she earned her Master's of Public Health degree from the University of Washington and has worked in many positions locally, statewide, and nationally, building programs and systems in relationship with many tribal nations. Today, she is the executive director and co-founder of the Tawat Birth Justice Center, a grassroots social justice organization located on the Yakama Nation Reservation, where she and her team diligently work to change maternal and child health systems, provide supportive care grounded in our cultural values, and access to exceptional health care for Indigenous birthing families. Her passion is fighting against oppressive systems, creating new paths that honor tribal people's history, culture, and strengths, and building an organization that allows all to thrive. Please welcome Jessica.
Okay, hello. Well, I'm the last person. Everyone gets to go do the rest of their day, so I'll try to make it fun. This is my cute baby grandson, so you'll see him, here and there, because anyone that's a grandma knows. So I'm Jessica, as you just heard. I want to just say a little bit about myself, and also I want to say a little bit about where I'm at, this land. I like to find out and figure out who the indigenous people are, where we're at, and here it's the Sac and Fox people. And I actually grew up in Kansas, and so I was able to come home and see my father and spend some time with him, which was really special, and smell the smells that raised me and hear all the bugs and, the things that are real familiar to this land. And as I'm Winnebago, which is right, the Winnebago tribe in Nebraska, which is right, not very far from here. So I have got to spend some time on this land. I just wanted to bring that up about the indigenous people here. Okay, so today we're going to talk about what Indigenous birth justice is from just my perspective. There's a lot of different perspectives out there. What our experience has been with trying to deliver doula care and get doula care going, and how we're implementing restorative justice in our organization and the work that we do, and just some of our future plans. Yeah. So I think I just like to hear what other people's, before we get started, because I think people's ideas change by the end of this presentation. So I just want to hear maybe a few people to tell me what your idea of Indigenous birth justice is, or what you think it could be, or ideas and thoughts. So just a couple people.
I would say the right to tradition, or the right to operate as you would like.
Is there anyone else? No? Okay, you don't have to do it. It's fine. So it's fine. I think, so I feel like, so yes, culture and ancestral knowledge and this resurgence of that is huge, right? Is that we still have all this indigenous knowledge in our communities, and it was taken away, right? Colonialism came in and took a lot of that from us, but not all of it. It's still there. So part of it is bringing back that that ancestral piece of our work around birth. I think of so birth justice, when I think about it, and for us as indigenous people, it changes all the time because I'm learning so much. So what I would have thought of it being a year ago is different than what I think of it now. It's like an intimate relationship that you just get more deep into and as you learn. But I think of it as really it's centering the whole family, right? So it's creating and there was someone on our team that actually said this, that she said it's creating a healthy birthing community. So we're trying to create, with our culture and our traditions and our language, a whole community that's centered around birth, but it's actually all encompassing of everyone and everything, because that's what life is, right? So we do that in a lot of different ways, which we'll explain to you more. So in Washington State, which is where I'm from, I'm from here, but I've been there for like a long time. We just got the stats back, I don't know, it was like 2 years ago or maybe a year and a half, that Native women are 8.5 times more likely to die from maternal-related deaths compared to white women. So we have very high rates of death. And we have seen it in our work. I've been doing this now for 13 years, and I can't tell you how many women that we've cared for that are no longer with us. So I just want to give you like this nice, Ebony came, where's she at? She came to our place. Yes, she did. So actually, Ebony sat right there in the front lawn with us. So I want to give you an idea of where we're doing our work and how. So the Yakima Nation Reservation is 1.5 million acres or something like that. So it's huge. It's a huge piece of land, very rural, way out in the middle of eastern Washington. So a lot of people think of Washington as like green and rainy and all that. No, we're in a desert, and it is hot and it is cold. And right now it's smoky. And it's very isolated. We're very isolated from resources compared to people on the west side. So this is our house. So this is where we operate all of our work out of. It's a little farmhouse at Campbell Farm, which Deanna runs, and she's also on our board. And we started out, her mother was on our team that brought us to Campbell Farm because we had nowhere to do our work, and started us out in a teeny tiny little room behind her office. So we actually started just mentoring women in a little office on a farm in the middle of the reservation. Okay, but we love this house. It is too small. So in that little house, when you come in, we have a clinic in there. We have a request from the chat to hold it closer. Okay. Ooh, okay. So out of our little farmhouse, we set up a clinic room, and we have a clinic once a week there with the OBGYN that comes in and provides care. We started a needs assessment a long time ago, and one of the biggest problems that we have is access to care. Any kind of care, any kind of resources, any kind of anything. But this is what you'll see in our house. You'll see families we have that come in. This is one of our babes in play groups. And we have a clinic, and we have all kinds of other services, breastfeeding support. We do food sovereignty work. A lot of our culture is based around food. And so that's just a little snapshot of that's the house that we're doing all of this work out of, and a cute picture, because everyone loves cute pictures. So just a little bit of history to give you more of an idea. So we did start in 2012. We began as a coalition, and it's crazy, like I think about how time has flown by so fast. And then we began our first community needs assessment, which someone was talking about data. We got out in the community, we started interviewing people, we started talking to people, what are your experiences with birth? What are your experiences with healthcare? What do you want in the community? What have you, experienced in your life? And we learned so much from that one needs assessment, and that's actually what was the foundation of our work and the design of our work. And so we started direct services in 2014. Like I said, it was small. It was like counseling women and talking to women about getting to prenatal care, because one of the things we found is people wanted to go, but they didn't have a car. They didn't have transportation, have gas money. So fast forward 2019, we finally became a 501c3 right before the pandemic. So we had opened our doors, and we were so excited, and then we shut everything down. So it was so sad. But we took that time. We still serve mothers. We took care of them, our families that we served virtually, and sometimes we got to see them in person. I think we had about 70 families that we cared for during the pandemic. So we opened clinic in 2022, and we only do clinic one day a week. So the rest of the week we do other activities and do organizational development and stuff like that. But the first year we had 250 office visits, and that was one day a week, and about 20 births. A year later, we had 560 office visits and 50 births. And for a tiny little farmhouse, in a tiny little room, that's a lot. That's a lot of people coming through. So our families come through our house, and they get their care. We do GYN visits too. It's not just prenatal care. And we're able to catch our families. And so we're like, hey, on top of getting this care, and it's awesome because they don't have to drive far and it's on the reservation. It's the only place you can get prenatal care on the reservation. We can do all of these other things with you. We can do education, we can do breastfeeding support, we can care for you with plant medicine, we can teach you traditions and culture, and so that's how we're able to stay engaged with our community. Just to, you know, the population that we care for, the families we care for, there's a lot of mistrust in the system. And also because of history, right? Like, let's not pretend that all of the things in history didn't happen to us, because they did. So it results in all of these things. Like, we have really high rates of missing and murdered Indigenous people on the reservation. There is a mention of like the sexual and physical violence that people are experiencing, and like, how do you care for your team who are taking care of people that are experiencing that? We went through a whole policy era of taking away children. We had a whole policy era of forced sterilization that was happening. And now, like, you can see that those rates for infant mortality and our deaths are astronomical. So this is my daughter in my bedroom. I was like, hey, does anyone have babies in my house? I don't care, it's fine. So we're doing this work through healing. So we really believe that the foundation of this work is grounded in healing. And it's healing the ancestral trauma, the historical trauma, the systematic racism. I mean, the things that we're doing, the building of new systems, providing safe spaces, supporting, you know, each other. It's all healing, like, it's a healing experience, and it's grounded that way in the work that we do. So some of the stuff I did want to talk about with, so this is our team. There's one more person. Our team was 5, and then we lost one of our team members that we cherished and loved very, very much. And so then we went to 4, and now we're back to 5 people. So similar to you, I did this work for free until May. I don't know, it's been a year and a half. So I finally got a salary. Yeah, but I was the last person to get hired. I was like, all these guys had salary, you know, full time, and I was like, I'm coming, I swear, I'll get there. But I wanted to, you know, I was like, I can always get a job somewhere. I want to make sure you guys are working. So anyway, so now we're all together, yay. And it is my full-time job. So one of the things that we're doing, or one of the things that I, with my heart, and I feel very passionate about, is this restorative justice work, right? Which is creating an organization and providing the service and care with, not with the policies and procedures and practices that are oppressive and that aren't honoring us as Indigenous women. The fact that we have families, we are working really hard, we are the people we serve, we all come from backgrounds of trauma, we're having to deal with our own grief and losses and also care for the people. And so we're trying to also develop an organization that is supportive and encompassing of all those things. So I like to think of, and it's not easy, I have to say, I'm like, what did I get myself into? It's a slow process, and I think it takes a lot of observation. So I feel like I'm like constantly observing, like, how are people maneuvering themselves, our team, as Indigenous women that are serving Indigenous people, and take care of them in such a way that they're able to keep going. Staff turnover, we don't have it. We don't have staff turnover because everybody is so passionate about this work, but also we're very embedded into the community. So anyway, so yes, we're working on this, trying to do that developmental work in our organization. One of the things that we're doing is I have an elder that comes in and works with us. She's a healer, elder, Indigenous woman, teaching us about how to regulate our bodies, our emotions, when there's something that's hard that happens, like a mom that passes away, or a family member that passes away, or some, you know, those big things that tend to kick you down where it's hard to get back up. She's trying to teach us how to not let ourselves fall too hard, you know, where we can pick each other up and ourselves up in a more gentle way. So we're doing that, and everyone has access to free mental health care of their choosing. So they get, we found a pretty good social justice-centered mental health care place that provides therapy for our staff. So we're trying to make sure that we take care of each other and our team that's caring for others in such a way that honors who they are. We also have a sweat lodge, which we've only got to sweat together once. It's at Campbell Farm, so we have a sweat that's there for us to practice our ceremonies together. We've done a lot of ceremony together as well, so we get to do all that kind of stuff. So that's like some of the part of this work that I think a lot of people that do the work know that it's there, that how diligent you have to be to not lose your mind sometimes. So anyways, so the systemic racism, there was a question that you guys had wrote about, like some of the stuff that we're working on in terms of like policies or, which systemic racism is absolutely one of the hardest things that we're having to battle at every corner of this work, especially when it comes to policy. But there has been a very intense historical and current mistreatment of Indigenous people in the medical system. This has not stopped. We see it now still. And when I started this work, when I remember someone asked me, what is the root cause of infant mortality? And I said, systemic racism. Racism's the root cause, not because people want to blame us, right? It's you're not doing this and you're not taking care of your body right. And you're not, no, it's actually the system. We don't have access to healthcare facilities. So we did have a hospital at one point on the reservation. They shut it down with no notice. We have no place to get prenatal care. And the places that you do go, you get 3 to 7 minutes. They're FQHCs. So you come in, they get you out in 3 to 7 minutes. That's the max amount of time that you get to be there. There's also, I've noticed that there's a lot of training and institutions and people are capitalizing off of the uptick of let's talk about maternal health, and there's more funding coming through and there's more resources, and I'm seeing like places kind of like catching on to that and opening up doors or doing trainings that have never actually done any of the work. I've also, there's also a lot of lateral violence that's happening, not only in our community, but on boards or in this field in general that I've also noticed. I know I've talked to several EDs and founders of these organizations that are doing this like really hard work, and they're getting it really hard, like really hit hard, and by board members or by community members or by colleagues, and again, like this is all these things that are coming from this system, right? And so those are things that I think about, how can we change that, or what does that look like in our little corner? I was like, maybe we need to get more resources to the board of directors. Like if there's an Indigenous woman on our board, like what can we provide for her to make sure that she's also healthy and doing well so that it serves our organization? So there's a lot of things that I think in the system at every corner, whether it be the medical system or lateral oppression or your own personal self, like it's coming at you at every direction when you're doing this work. Because it's, let's be honest, we're Black and brown bodies that have been a target for a very long time, and that has not changed. So another thing that I also have noticed a lot is the fact that like we're way out in the middle of nowhere on a reservation. We don't have access to the dollars, the capital, the philanthropists, even the time to come and talk and do stuff like this, right? Like it's hard for me to get away and go talk because you're out here doing the work. But the resources that I have seen come into organizations on the west side of the mountains versus in our area are astronomical, whereas we're like begging for dollars to keep our doors open. So there is a huge divide in philanthropy as well. And that, again, part of systemic racism. I just want to share another picture because they make you happy, and this is awesome. So this is Shanita. So Shanita was one of the families that we took care of, and her husband. Actually, her husband is interested in doing what you're doing. And so when I heard you talk, I was like, okay, I need to go back and get Colby connected with you because he's been so inspired by this work as well. He's like, I want to get involved. How do I get involved? You know. So she was so inspired by the work that we do. She went and got doula training, and I was able to hire her. So now she's on our staff, and she's amazing, and she's young, and we love the young energy. When I hired her, I was like, we're so happy that you're here because we're all old and crotchety and tired. And she's young and like, you know, spring chicken. We're like, yes, you know. So it feels good to have a staff. It feels good to hire people from our community that were inspired and loved by us. And so that's what we're doing. Okay, so like I said, when people come through our doors, there's all kinds of other things that they can get besides just medical care. And one of the questions was like, how is doula care? What did that look like for us? That was one of the things that they sent out to talk about. So it's been a really interesting journey. So we started, you know, our journey 12 or 13 years ago, however long ago that was. And what we found, because of our location and because of the lack of capacity and people that we have to do this work, it is so hard to have a doula and keep a doula. We have everyone on our team, except for me, has been trained to be doulas. They deliver doula type work, but they're not really specifically like where you do the, you know, here's how many things that you do before, or how many visits, and then you do the birth, and then there's 4 visits after. We actually don't do that. The trainings have been really beneficial for our team to build knowledge and gain knowledge, but the fact is that it's hard to, as they mentioned, like everybody has kids. Who's going to babysit when there's a birth? What if you're gone for 2 days because of a birth? What's going to happen to your kids? Like, does this person have a supportive partner? The kind of care that they provide also is very intense because it's our community members, and if they're wanting something, you're not like, oh, this doesn't fit in our two-visit doula, you know, window. So it really hasn't worked well for us, and it makes me kind of sad. But what we are actually moving more towards is thinking about like the whole family, right? Like, so you're kind of talking about how you're training like the dads, right? How do you train the whole family to center and care for that person? And we're looking at like, what does that look like and how do we build that? Because we will continue to not have resources. It's not like all of a sudden someone's going to swoop in and, you know, give us a bunch of resources. That's not going to happen. And so that's what we're moving towards. We do have, if there's 2 people on our team that will do birth doula, and I told them, okay, if you really feel like you want to do that, you know, keep it to like maybe 5 a year. And the rest of their time is spent educating, doing breastfeeding support, doing educational classes, doing mother support groups. So that's the direction that we're moving in terms of the supportive care that we do on top of, you know, having a clinic. So our vision for the future, this is our birth center / wellness healing space that we're working on building. So you came out to the land, so you know that where it's going to be. So Diana, she runs the farm is 40 acres, and she's looking at donating 5 acres. So this space would provide the 4 birthing suites, There's a clinic space that we plan on not just having OB and GY in, but also pediatricians or, whatever practitioners want to come in to our space and provide care for our community. We have an apothecary, so we do a lot of plant medicine work. And so that little building over there is apothecary. Well, it's on this side. Oh, your guys's, it's the side, that little one. So opposite. And then the back part, that back house, the curve with the curves, it's a family house. So it's not just a medical facility, but it's like where people can come and gather. They can come and process foods. They can come and sing and dance and, do all of our cool indigenous things that we like to do with each other. And yeah, so that's where we're heading. I also am hoping to training into like a training center as well. So we're working on developing a provider training series right now so that we can take that out and start training providers about how to work with indigenous people in this world. So anyway, so yes, that's what we're doing for the future. Another cute picture because everybody loves it. This is Tashina. She's one of our staff members. She's a IBCLC, so she provides breastfeeding support, and she was a nurse for 20 years. I always call her my bulldog. I'm like, oh God, do I got to stick Tashina on her? Like, or Tashina on them, like people are acting up too bad. Not our people. It's all the other people that start acting up. I'm like, don't make me pull her out. You don't want her. So anyways, yeah.
That is in the birthing room and how important that is like in all the care that Tatawak does, because I think like you missed that little part, and I think that's a really kind of important piece.
Thank you. See, look, I got backup all the time. Accountability, right? Dang it. Yeah, so yes, so we do, so I look at it as like, it's who we are, right? Like we carry our traditions and our culture with us, and so we get to share that with all of our folks, our people that come in. And it's also we're working with the hospitals and trying to get them to not be, I'm going to say nice words, difficult, and try to get them to not be difficult when we come in and want to practice our cultural ways. And so there's a lot of learning that happens when people come in to our space. We do have elders too that come into our space that teach and talk about the culture and traditions around birthing. And we look at it as a ceremony. So just as a funeral is a ceremony, we have big funeral ceremonies that last days. So our funerals are very long and they're very encompassing of teaching and culture and songs and dance and all that, and same with the birth, right? So there's like songs, there's plant medicine that you use, there's teachings that you talk about, so that people know that the ceremonial part of birth, right? And so that's what we're instilling and bringing back, and it's beautiful. I mean, it changes your perception of your experience and how you want to have it in this world. So is that good enough? Yeah, you can say something. or the uncle role, because it is a huge thing. Before, we were birthing babies in hospitals, we were doing it at home, and you were surrounded by your community. You went home to your community, you're well cared for, and with like the plant medicines, having the proper nutrition, and that comes from our own garden right now, right? And having someone to care for you, prepare you, having, and if you don't have it now, because there's not very many
at Tatauak, they're having those things. Like, it was really important that you showed the picture of, you know, our elder who's actively participating, because you need access. Because our culture was robbed from us, we're bringing it back. And so you don't have all those pieces that you need in your family unit. And so Tatauak offers that. The women offer those things in a place that's safe and on their terms, on our land, and not in the hospital. And so the advocacy work is really important because, like I said, hospitals are fighting against it. But when you have like people like Jess and the other women who can come in and say, no, this is how we're going to treat our elder, and this is what this woman deserves. So that their program is really unique in that way because it honors our First Nations people, it honors our Indigenous practices, it honors our traditions and our culture, and it's bringing it back. So that way, you know, like my daughter, when that's time, God forbid, anytime soon, is there in that moment. I know my traditions, and I know that, you know, her partner is going to be able to have access to knowing how we're going to take care of her, how our whole community is going to show up. It's not just birthing on your own, you're birthing into a community, and you have that support. Sorry, Jess.
I love it. I love it. I want to say our team we're like sisters. We've been together for a long time. Geez, Deanna and I go back really far, some 20 years, you know, but we live life together. We do life together. We support each other. So yeah, I mean, of course, I don't care, whatever you want to say. Don't tell them anything that they shouldn't know. Okay. Okay, do we have time for just a few minutes of a video? Okay, so this cute little video was on Good Morning America and ABC, I guess. But we'll just do the first little section of Tatauak because it's kind of long and you don't want to sit here for 5 minutes watching a video. So how do I click on the thing? Is someone else doing that? There it is. Perfect.
Now, with an important medical concern across the nation, the number of maternity care deserts are increasing. Now, with hospitals and delivery units across the U.S. closing their doors, leaving expectant mothers searching far and wide, often traveling long distances to seek any kind of maternal care.
Yeah, that's right. ABC's Faith Abube spoke to mothers struggling in some of the most impacted areas, including the Yakima Nation grounds in Washington state, with few options to turn to as they near delivery.
We're getting back into our normal lives.
Early on in her pregnancy, Tori Washelley made plans to deliver her second child in the same hospital as her first, Astria-Toppenish Hospital on the Yakima Indian Reservation in Washington state. But with just 3 months left to go, the hospital suddenly shut down its labor and delivery ward, leaving her scrambling.
I think it was just nerve-wracking.
Sierra Wheeler was more than 7.5 months along. The hospital closure would mean a 45-minute drive to the nearest delivery unit.
It was something that I was stressing about.
The Yakima Indian Reservation spans more than 1 million acres, and pregnant women looking for care are often forced to travel roads that can easily become dangerous depending on the weather.
The traveling distance plus the resources that are needed to get quality care are not there.
Jessica Whitehawk founded the Tatauak Birth Justice Center with the help of birth advocates Leslie Swan and Simone Dittenholler.
It's a fresh light. We're providing a safe space, whether it's for 5 minutes to an hour. We invite all of our moms to come back and take a load off.
Let's get baby's heartbeat.
Dr. Anita Showalter schedules clinics at the center every Wednesday to see pre- and postnatal patients.
Every woman deserves to have her baby in a safe place.
A recent March of Dimes report found that over a third of U.S. counties are maternal care deserts. That's more than 2.2 million women of childbearing age and 146,000 babies born in areas without obstetric providers or hospitals or birth centers offering obstetric care.
Obstetrical units and hospitals have been closing across this country, and obstetricians, we're not increasing them.
That was just a little glimpse of, you could see more of the setting where we're at, the house, the clinic room. Yeah, so how much time do I have? Is it question and answer time? Nice. I'm not really great with timing, so I feel real proud of myself right now. Okay, is there any questions?
It's at work. Hey, it is working. How can we, since we do have folks who are watching virtually, how can we help donate to get you that super awesome hospital?
Yeah. Well, we have, so I would say if there's big gifts to email me, because you don't want to just donate on PayPal. It's probably not the best way. So you can email me. These guys all have my contact information. And then there is a PayPal link on our website if you want to go to our website and make a smaller donation. But we are, yeah, I mean, this is kind of like a soft launch, I suppose, of the birthing center. So, yeah. Is there other questions? Yeah, it's around $12 million. So we got our, like you saw, the first design, and we got our bids back, and we're waiting for hear back on land. So so it's around 12 million, which when I talk to me, that seems like so much money, because I'm like, how am I going to do that? I have no idea, but we're going to figure it out. Okay. So, but when I do talk to people that do capital campaigns, like, oh, it's not that much. I'm like, how? Jeez. Okay. Yeah. So, other questions or comments or anything? No. Do you need to hear any more bad jokes? I do have to say, I think something that was so beautiful was watching my grandson be born and my daughter get care at our clinic and be born through a system that we created for them. I didn't think I was going to see that in my lifetime, to be honest. So her care that she experienced compared to my grandmother, who gave birth to my mom in a hotel room because of racism over here in Lincoln. It's that big of a change in that many generations. And so to me, that was like, it was very emotional, and I get to see this work actually happening and making a difference.
I'm 5 feet from you. So you probably may or may not have these stats, but just curious, compared, like these stats of Indigenous women at 8.5 times more likely to experience a disparity of maternal or infant mortality, is that in the traditional hospital system that we're seeing those rates? And how does that compare to birth rates within the reservation in these home birth settings, et cetera?
Okay, so the thing about the data that came out is that they're only recently collecting accurate race data through the death and birth certificates. So I actually think that number is going to go up. That was their first stab at actually trying to reclassify things and really looking into cases. We don't know whether it's a reservation or the state, because I think the numbers are still too small, probably, or like it's, they're trying to figure out how to break that data down. But if you do want to check out, because they changed the indicators of maternal-related death, which I hope other states do that. If there's anybody listening, check out Washington State's indicators. Because it includes things like racism, domestic violence, overdoses, car accidents, and stuff like that. So when they included all of those indicators, the rate shot way up. So, yeah. But I don't know if that answers your question, but it's not broken down really detailed just yet. Anyone else? No? Great. Thank you, guys.
All right, so I get to close out today. So I'm Lastasia Coleman. I'm the board president for March for Moms. So I just want to take some time to thank everybody for coming out today, both here in person in Des Moines and virtually. I want to make sure we thank our sponsors, Brief for Organon, and for coming out and being one of our main sponsors for this event. Mid-Iowa Health Foundation was also one of our sponsors for this event. A couple of reminders. We will have a event this evening. We Can't Brew It Alone is what we're calling it, and it's at the Iowa Tap House. So hopefully we can see you all there at 6 p.m. tonight. There are still a lot of complimentary tickets left, so even if you haven't decided if you're going to come or not, please come on over and bring your friends. Here in person, we have a lot of food left, so please take whatever you want. There's a lot of leftovers over there. And then this event is recorded, and so we'll get it posted on YouTube here as soon as the recording's available, so you'll be able to watch it back if you need to go back and, you know, reference or watch some parts of the day that you weren't able to attend. So, anything else, Lanicia? Did I check all the boxes? Okay, sounds good. Thanks everyone, and have a good night.